Hey, Dr. Zhang, welcome.
Yeah. Professor Zhang is coming.
Hello.
Hey.
Hello.
How do I share? Can I test my screen?
Sure.
Yes.
Desktop 1.
Okay.
Am I desktop 1? Must be.
Yes, you are the first speaker.
So how do I upload? Oh, here. Okay, so just
Yeah.
share here.
Share the screen. Yes.
Yeah.
Share computer sound. All right, where do I? Hold on. File. I don't see where I can actually. You can access my computer. When I click on share screen, I don't see where I can access my my local drive.
Oh, you do not need to access local drive. You just share the screen. We'll show you how to do it.
I'm sorry, say it again.
You just share your screen and we are going to show how to do this step by step.
Okay, hold on, share screen.
Yeah, just do share screen.
Okay, I'm now here in share screen.
Yes.
But we cannot see your screen.
Open. Allow Zoom to share your screen. Open. Okay. Join audio. Join screen. Can you see it now? Or no?
No.
No. You have to press the share screen.
I'm
Yeah.
sorry. Say it again.
Go in. Can you show your screen first? And
Okay.
I did actually do that. Okay, hold on.
You saw my screen? See my
Hold
screen?
on. Give me a second. Yeah, I can see your screen.
Yeah, I can stop sharing. Okay.
Okay.
Just that's in the bottom. That's participant Q&A chat, and then share screen. Yeah. So you have to press that one, and then you can choose a window. Usually it's where your PowerPoint presentation is running, and then you can actually show your share screen with us.
Let me actually launch the PowerPoint. It can't. I mean, I won't have a Microsoft OneDrive, Google Drive box. I only have those three. Let's see, file, basic.
Did you
advanced?
Do you have press the share screen button?
I did.
And then you have to choose a window because they will pop up a small, how to say, a set of the window allow you to choose one.
No, I don't see share. They need.
Test.
Oh, hold on. So there's PowerPoint, local, contacts. Hold on. I'm actually Zoom. No. Share. Hold on. For some reason, I can't. By the way, I don't. Do I need to download the Zoom or I click on here? Click here to join the meeting. I did
Yes.
join. You don't wanna. Okay.
Since you have successfully, appeared in the panelist, usually means that you have all the software working actually.
That's
Okay.
right.
There's two buttons. There's one says
Okay.
participant, chat, share screen, record, record,
Just
Q&A.
you just
That's
click
share
the share screen.
I did, and then hold on,
You have to
Safari,
choose one.
Microsoft.
The-
There's a bunch
so
of stuff there.
there's nothing to do with your Microsoft PowerPoint. You just operate on this Zoom interface.
Yeah, I know, but I don't see. I see basically this window pop up, and there's a desktop one, whiteboard.
Yeah, you have to choose one. Yeah, you either choose desktop 1 or desktop 2. Choose any one of them, and then we can show you how to do it.
Share, okay. But when you say allow Zoom to share your screen, and then it led me actually to open system preference. There must be something in my system preference I didn't open that I cannot share yet.
Maybe Professor Zhang's video was not open.
Yeah. Okay, yeah. You're right. Okay, let me actually get rid of the video. You cannot start your video because your host has stopped it. Can you actually allow me to?
Yes.
Okay.
You can
So
start your
Professor
video.
Liu, yeah.
Okay, good.
Okay.
Yeah, here we go. Cool.
All right.
Yeah, we see you.
Okay.
Great.
Good.
Can you do your screen sharing?
Oh, good. That's the reason. All right.
Yes.
But still, it has location service calendar. It has a bunch of stuff. Privacy. It basically has general file vaults, firewall policy, something. I don't know where. It still doesn't allow me to share. Let me try one more time. Do I need to launch some kind of a Microsoft PowerPoint unknown or something? Safari unknown, iPhone, iPad cable. Allow Zoom to share your screen. It always goes to system, open system preference. There must be something that is not working. If I send you just by as a backup, if I send you my slides, is there any way you can load just as a backup? If we couldn't figure out before the meeting starts.
Yes. I think the best way to go is still you share your screen. So you already open your video. Let me see. Let's see. Do you see the share screen button at the bottom?
I do.
Can you click? So let's go through one step by step. Can you click the share screen?
Yeah. Okay.
Yeah. And then what do you see?
I see basically a pop-up screen. Say desktop 1 on the left side corner, and then there's a whiteboard. There's an iPhone, iPad via AirPlay. There's an iPhone, iPad via cable. Safari unknown.
Then can you click the desktop?
Do I need to click on share computer sound and
Yes.
Screen?
Yes.
Up the screen share without okay.
Yes. And then at the right bottom, you see a share or something like that button.
But when you click a share, it basically there's a pop-up says allow Zoom to share with your screen.
Do you have a cell phone with you right now?
Yeah. I had
So
to
let me call you and can you do a video chat? Let me show you how to do it, okay?
Okay.
我先去干活。Oh, sorry.
You can call me from good.
Yes.
Okay. All right.
Yeah. Can you put a cap? Yes, on this. Yeah, click the right one, open.
Okay.
Yeah. Oh, you're using Apple.
Yeah.
Click the first one. Click both. Click both.
Which one?
There's two buttons. The two buttons. Click check both.
You're basically let me turn off my sound because there's a lot of actually noise here.
Okay.
Okay, go ahead now. Tell me what to do.
Then check both box.
Which one?
See, you see the
Oh,
Microsoft.
yeah, got it here. Okay.
Check both.
Okay.
And then can you move your and then save it.
How do I save? I don't see a place you can save.
Oh, you just close it. It's fine.
Okay.
Close this. Yeah.
All right. And go again.
Yeah. Do it. Yeah. Click.
Oh, okay. Hold on. Now it's good. Here.
Yeah. Here we go. Yeah. That's it. Can you see your screen on Zoom?
I do.
Yes. That's what we need. Okay. Great.
That's it, right? You can see.
Yeah.
All
you
right,
just
cool.
do your
Okay.
presentation on your desktop, and everybody will see you.
Okay, cool. Okay, got it. Thank you.
Thank you.
Okay. Bye.
Dr. You can exit the screen sharing right now because first thing yes, that's good. Thanks.
Can I test? Can I test the screen?
Sure.
Okay. Okay, so let's just. Yeah, can you hear me?
Yes.
Okay, looks
Yeah.
cool. Oops, oops. Oh, I didn't turn on my. Hold on a minute. Oops. Oops. Test. Yes, it's my sound. Okay.
OK。OK。你刚才应该没听见我在说话对吧？我没有听到的。对，我有勾思路的。OK，跟这个昨天的顺序一样，你就这个前面讲几句话，我后面就是会勾思路这个昨天的东西，今天要讲的东西。OK，跟昨天一样，可能会花这个将近10分钟时间。OK，好不好？OK，我现在出去做点事情，我这个刚到家里面。OK，人都没搞过。OK。
Hey, Changjin, do you want to share, try your screen sharing? Changjin? Changjin, are you there? Changjin, can you hear me? Oh yeah, I see you. Hey, Changjin, can you hear me?
I just contact with him and maybe he's trying.
Yeah, I see he said okay, yeah. I do not hear your voice. Changqing, can you hear me? Can you hear us? Oh, yes, good. Hey, Changqing, can you say something?
Hello?
Oh, yes, good. We can hear you.
Okay.
Can you share your
Can
screen?
I try to share my screen?
Yes, please.
Okay.
Oh, cool. Great.
Okay. Okay.
Yeah, good.
Okay. Thank you.
Thanks. Cool.
Hello, hello. Can you hear me? Can you hear me?
Yes, yes.
Okay, okay, thank you.
Hey, Ding An.
Hear me? Are you calling
Yes.
me?
Probably I will turn the practice mode to broadcast mode, so we can add all the attendees in. Okay.
Yeah, you can do that now. It's just 5 minutes.
Yes. Changxin, can you mute? I'm gonna mute you, okay?
Mute everyone, okay?
Okay.
Yeah, not me.
Right.
All people in the panel need to be very carefully to mute yourself when you actually not talking. Otherwise, it will be very annoying. People can hear you during the talk.
Hello, can you hear me?
Yes.
Dr. Zhang?
Yes.
Yes.
Yeah, we
Can you hear me well?
Very well.
Good. Excellent.
So you will be the first one, and I will introduce you, and then I will stop sharing. Then you can share your screen.
Sure. And then you're gonna remind me how many? 15 minutes?
20 minutes. And also, if you need a little bit more minutes, that's fine.
Okay. All right. Thank you.
Yeah,
You can.
You have a lot of experience using AI for different kind of medical application.
Okay.
You can take a little bit more time. I think many people mentioned to me they want to listen to your talk, so they are
Okay.
look forward to your talk. Yeah.
Thank you. Okay. Sure.
Welcome.
AD 哥，你说，什么事儿？我知道了，我知道，我。Hey, curious, is this seminar open to everyone in the world?
Yes, I think so.
How do people access or chime in to listen to this presentation?
They can either attend by joining the Zoom meeting or watching the YouTube online or watching the Bilibili website. We have 3 channels.
Can you send me through my WeChat the information how to join?
Yeah,
Or
sure.
just group?
Yeah.
Yeah. Okay. Thank you.
Sure.
Timmy, can you
Yes.
check how many people are watching YouTube right now?
Not many. Right now, there are 12 of them are watching YouTube right now.
Okay.
Maybe it's early in the morning.
Early in the morning. Okay.
Yeah.
So
After-
Bilibili line 895.
After yesterday's webinar meeting, there are the 280 people watching the YouTube link in total.
How many people?
280.
Oh, okay. Let me
Yeah.
try my video, where the video works.
Okay. Maybe we should get started. It's already 8 o'clock.
It's up to you.
Yeah. So I think let's get started. Good morning, good afternoon, good evening, everybody. Thanks for joining us today for the second webinar of COVID-19 AI series. Today we're going to have 8 speakers, 8 talks. First, Dingang, we're going to introduce the webinar and the speakers. Dingang, please.
Okay. So just like Timmy mentioned, this is a MICA webinar. The title is Imaging AI-based Management of COVID-19. And Tianmin, Guoye, and I co-organize this webinar. And this webinar actually technically supported by Jun, Wei Guang, Qian, Dong, and Si Hui. And also organization supported by MICA Society and also Mix China. And this is sponsored by Shanghai United Image Intelligence. So before this webinar, actually we already did preparation on May 9. At that time, actually we have 2 1-hour talk. I gave a talk on integrating AI in imaging quantification, identification of COVID-19. And if you are interested, we have the videos in YouTube, also in Bilibili. Second 1-hour talk is given by Sui Wang. He talked about the deep learning on image and graphics, and particularly some applications in COVID-19. And also we have the video provided in YouTube and Bilibili. So yesterday, actually, we gave, basically we have 7 talks from 4 countries, and most of these speakers actually talk about their work published in TMI, 3 TMI, 1 radiology paper, and also Nature Medicine, and particularly Dr. Siyue Liu, who is elected chairman for Chinese Society of Radiology. He gave an overview for using AI fighting for COVID-19 in China. So today we are going to have 8 talks, and all the speakers will be from 5 countries. And the first talk will be given by Dr. Kang Zhang, and I will chair his talk, so I would introduce him more in the later. And also, 4 speakers will talk about their work recently accepted in IEEE translation on medical imaging. And also, one of the speakers, Wailo Nissen, coming from Netherlands, he's going to talk about technique or strategies they are going to use to build a Dutch database for imaging and clinical data. And also people from Cambridge and also University of Pennsylvania. Actually, my former colleague, Jim Ji, and also his collaborator will talk about the strategy used in University of Pennsylvania. So very quickly, just introduce some points for the COVID-19 applications. And I think, for all these applications, it should be like a full-stack imaging AI, starting from continuous imaging, like before imaging, to help protect technicians from COVID-19 when you acquire CT images, immediately AI problem is to quantify infection, and then for all the CT images as well as the clinical information, further testing, experiment data. And the questions you want to answer is how to assess severity. So yesterday I also mentioned actually we have one invited review paper in IEEE reviews in biomedical engineering. So from this review paper, we can see most of the papers actually use a UNet or VNet. And this method are used to segment lung or lung lobe or lesions. Here is the infections. And also, you know, for doing all this kind of task, for example, diagnosis, 60% of people use CT, 40% of people use X-ray, and also the method, for example, the question people try to solve is like 50% of papers try to classify between COVID-19 and non-COVID-19. 43% of paper used to separate COVID-19 from other pneumonia. Very few papers actually used to assess the severity for the COVID-19 patient. And 80% of papers use deep learning. The remaining 14% of papers use a traditional machine learning algorithm. And also for all this method, for example, 57% of method actually achieve over 90% of accuracy, and 40% of the method achieved 80 to 90% of accuracy. These slides, I just want to show you many papers actually talk about yesterday and also today. They basically focus on the first problem. For example, when you acquire the CT image and the patient is still in the table of the CT scanner, then you want to see whether this patient has a COVID-19 or just community acquired pneumonia. So this is a question people ask a lot. But you know, other questions, for example, if a person with a COVID-19, where this person, the COVID-19 is mild or severe, this kind of questions was basically checked by very few papers. And also if you know a patient with mild COVID-19, then the question is whether this subject still keep stable or not progressing to severe or going to develop to severe. So these two questions, for example, this like COVID-19 to separate them into mild or severe or mild COVID-19, whether subject will develop to severe or not. These two questions actually are very, very difficult actually to answer. And also in the literature, actually, very little papers talking about the task of these two questions. So today, May 15, actually, we have 8 talks. I will very briefly mention the 8 talk. The first talk from Dr. Ken Zhang. So he's going to talk about his paper published in Cell, and he used one of the largest data set try to do the diagnosis. And also the lung lesion information or features will be correlated with the clinical data to see the correlations. So the second paper actually, I talk about, for example, many people use CT and X-ray. This is paper actually use ultrasound. So the people from Italy and the Netherlands, we talk about how to use ultrasound imaging for COVID-19. So third paper actually talking about noise in the labels. For example, if you delineate images, there are some labels, there are some noise. This is very possible because patients, physicians are very, very busy, so they don't have time to very carefully, label the infection lesion for you. So in this way, how to develop a noisy, robust, loss function, try to solve this kind of issues, then you can segment infections, and also you can segment, other lung structures. So number 4 paper actually from Changqing Zhang, Tianjin University, collaborating with United Imaging Intelligence. And he uses structural multiple representation algorithm to do diagnosis, actually try to identify COVID-19 from the community-acquired pneumonia. For example, in the training stage, he has 3 steps, and also in testing, then can directly input to the trainer classifier to do this job. So number 5 paper actually from Cambridge, and this paper actually going to talk about how to integrate or combine X-ray with CT, then you can do better diagnosis for the subject. So number 6 paper actually from Shanghai Jiaotong University, Dr. Qian Wang, he collaborating with United Image Intelligence. He is going to talk about using basically different attention strategy and also different sampling strategy. For example, uniform sampling and size balance sample. How can you combine different networks together to do the ensemble learning? And he also applied his method to one of the largest data set in this study, almost 5,000 images to diagnosis using this kind of deep learning algorithm. So number 7 paper actually from Netherlands, as I mentioned before, Welo Nielsen. He's going to talk about how to build Dutch database with imaging and clinical data for all this kind of COVID-19 study. So the final talk for today actually Jim G from University of Pennsylvania. Actually, like I mentioned before, he is my former colleague in University of Pennsylvania, and he and his colleague will talk about how can we integrate computer algorithm to help fighting COVID-19. So this is all the papers for a talk. And if you are interested in the COVID-19 study, and also I want to show you in this slides, actually we have several special issues. I organized the first special issue, I believe, in the engineering journal, actually in the IEEE medical imaging. Also, I work with Qianming and other colleagues for another special issue, actually in the medical image analysis. And this is the third third special issue are involved, actually in the pattern recognition journals. And the starting date will be June 1st, and the announcement for paperwork will become very soon. So these are the 8 talks. I will chair the first talk. First talk, as I mentioned to you, actually Dr. Kang Zhang. He will talk about his method developed for the paper recently accepted in Cell. Actually, Dr. Zhang, he published several papers in the Cell for AI applications in different kind of medical images. So Dr. Zhang actually, from what I remember, he graduated from Sichuan University, and then he got MD from Harvard and MIT joint program, and he also got a PhD from Harvard. And then he did residency in Johns Hopkins. Actually, I have a little bit overlap with him, but at that time, we did not know each other. Then recently, he moved to Macau University of Science Technology, China. So Dr. Zheng, it's your turn. I will stop sharing, and then you can share your screen. Dr. Zhang, can you share your screen?
Sure. Let's see. How do I?
Can you open? We can see your screen. Just open your PowerPoint. Open your PowerPoint. Yes, yes, yes. Click this using full screen. Yes, full screen.
Okay, very good.
Yeah.
Can I start?
Yes, you can start.
Okay, thank you. Thanks, Dr. Singh, for your introduction, and thank you very much for organizing this meeting. And And then also it was a great pleasure to share with our results with our colleagues all over the world. And it's interesting, this format is actually looks like is working quite well. And today, so I will talk about some of the work we did. I'm talking on behalf of the China Consortium on chest CT imaging investigation. So it's a CCCC 2 project, and we have another one on X-ray, and which has another acronym for this. So I don't have to actually tell you how important it is to diagnose COVID-19, and computed tomography has been an important tool in non-disease diagnosis, including pneumonia. And obviously, this has actually taken on a more important meaning in COVID-19 because of the shortage of nucleic acid-based testing methods. And in addition, CT can give you this quantitative measurements of lung lesions. So with all that caveats, and at least in China, at the initial outbreaks, and radiologists and the hospitals had been focusing on using CT for diagnosis of COVID-19 pneumonia. So there, just like Dr. Shen said, there are a number of issues in using the CT for applications of the COVID-19 diagnosis and the prognosis. And what we did here is to actually build up 2 models, and one is for a diagnosis. And in order to build a very accurate diagnosis tool, we found that it's important to initially do a segmentation and build a segmentation network. Therefore, we, our colleagues, radiologists, 40 radiologists, painstakingly painted pixel by pixel slices, which is about 5,000 slices. And from those slices, we'll train the classifier to segment those lesions, so 6 types of lesions. And then we also, and then we actually classify, we then taking end-to-end approach to have the computers learn these other features of the lesions. That's one. And the second one is we take the lung lesion features, combine them with the clinical metadata, try to correlate, number one, with clinical features, and then also attempt to make a prognostic analysis. So this is actually, as the first results, we were able to segment different features of lesions. This is including consolidation, ground glass appearance, fibrosis, interstitial thickening, and pleural effusion, some of the important features of a lesion. And this is important not only just for initial diagnosis. We found that often for the patients who progress into severe cases, critical ill patients, and eventually they will, the lungs will undergo fibrosis. And those are patients are important to be evaluated through quantitative measurements. So fibrosis segmentation are important. And so shown here are some of the features of different lesions. We were also able to reconstruct into a 3-dimensional lesions volume, as well as space relationships. And shown here is actually on the right side is a video, which I will not actually play. I essentially give you a straight, basically a rundown of where the lesions are. And so as the first initial attempt to address the diagnosis of novel coronavirus pneumonia, we call NCP. And we took few thousands of patients and over 300,000 slices, and as a training and also internal validation cohort. And we did it against several other pneumonia, and as you can imagine, so as a screening tool, we first need to make sure that it'll give actually very high diagnostic accuracy to normal lung, and also will be able to differentiate with other common pneumonia. Here, that includes bacterial pneumonia, viral pneumonia, and other pneumonia such as mycoplasma pneumonia. As you can see, that it did actually perform quite well in this regard. We also was able to do some prospective studies, both in independent Chinese cohort as well as international cohorts. In the Chinese cohorts, we took into consideration that different regions of China might have different rates of infections. For example, in part of the Wuhan, obviously, it is very high, infection rates are very high. So we did a prospective cohort there, and then I show actually it has very high accuracy. And then we also went on and did additional cohorts in the non-epidemic areas such as Anhui as well as Guangzhou, and those two areas, and which has the cohort. What we took is actually consecutive patients who came to the fever clinic, and obviously people come to, with fever with different reasons. One of which is try to make sure they do not have they don't have COVID-19 pneumonia. We use the standard nucleic acid based RT-PCR methods as standard measurements, and to make sure that we made a correct diagnosis. In doing so, that as you can see, we also achieved very high accuracy, overall accuracy of 90%. Another reason of using an AI system is to see how the AI system can assist our radiologists and ER physicians for the frontline diagnosis of COVID-19 pneumonia. In this case, what we show here is by training with about 300,000 NCP and other pneumonia cases, it can achieve quite actually good diagnostic accuracy. If you look at the panel C, so this is actually a weighted error, and it's about 9%, whereas the radiologist, average radiologist, the senior radiologist is performing comparable to the AI platform. But however, the junior radiologists are all over the place. If you look at the panel B, look at the initial junior radiologist performance, they are far beyond or far below the senior as well as the AI performance. In this case, we also allow the junior radiologists to assess the AI based diagnosis, and then I also show where the AI thinking, where the lesions are, and to give the junior radiologists opportunity to actually diagnosing the chest CT of the three categories. And this is again about 3 weeks later. We make sure that they don't memorize or remember what they have done before. As you can see, that this is actually can dramatically, the AI can dramatically assist and improve the diagnosis of the junior radiologists. So I think this is actually one of the more compelling reasons of AI, and we clearly actually see that the performance of a junior radiologist can be dramatically improved by the assistance of AI, and either using AI as a second grader, or actually or as a basic assistant with a first grader cases. So one other reason I thought actually it would be we thought it would be actually important for AI to perform is actually see how well the AI can predict other aspects of the systemic health. And the reason being that I think this is particularly important for CT, because the scanning of the lung essentially give us a quantitative measurement, so how big and small and how acute the lesions are. And because the lung function is directly proportional to the lesion size and the properties of the COVID-19, and we thought it had to be a way to essentially extrapolate and project the systemic health of the entire body. So this is actually, when we did this, we actually was blinded. We don't have any knowledge, because at that time some of the prognostic clinical factor papers haven't been come out. We essentially use big data and the long lesion, ask the question for essentially the correlation. As you can see in this slide, we actually show that age, C-reactive proteins, and albumin are highly correlated with the lesion size just by itself, by looking at the lesion size. And the lung and the liver function turn out to be, I mean, it's very conceivable that the lung function will be impacted on the lesion properties and size, and so as a saturation, CO2 saturation respiratory rate. However, what we didn't actually expect is actually the lung lesion properties was correlated very well with the other part of the function. So essentially, at the time, we thought that the lung lesion size or actually progression to the respiratory failure and be put on the ventilation, mechanical ventilation, essentially let us actually solely focus on the lung function. And this is actually AI-based, non-hypothesis-driven search let us actually start to think about some other systemic factors are going to be impacting the outcomes of the severity and outcomes of the of those illness. So this is actually what we actually found, and so not only we found the correlation, we also are looking at the lesion size of the lung and the features, plus the clinical factors. How would that actually be contributing to the progression to critical illness? By definition, those are admissions to the ICU, put on the mechanical ventilation ventilator, or death. And you can see here that clearly that the lung lesion play a major role, and then just by itself, we actually already give AUC about 83, 84%. And with the clinical properties, it can actually essentially raise up to the 90%. And in addition, we were able to stratify in figure panel E upon the admission of the patient to the hospital. What's the chance and how long it will take for them to progress into critical illness? Because that actually information is very important for the physicians, respiratory pulmonologists, the ER physicians, to strategize the strategy and allocating proper resources to make sure that we can alter the disease course in the beginning of the progression, such that we can reduce the ICU admissions. And because once we get to the ICU admissions, all the data show that there's a 60% mortality, and then a lot of actually things are already irreversible. Another function of the we thought that the AI can do is to for the evaluation of the drug treatment effects. So because of the AI, the CT-based AI system can do a beautiful job in quantifying the lesion size and properties. So in this case, we just took 3 drugs, and because at the time those drugs are still undergoing clinical trials, so we cannot actually break the envelope or seals for those drugs. However, we were giving the before and after treatment CT scanning properties, and we're able to look at the lesion size. You can see that, as you can see, clearly the CT can be used for measurements of the size of the lesion, as well as actually unique properties of the lesion. And you can, for example, quantify whether there's a reduced lesion, for example, or actually increased lesion or no change, or you can see whether there is increased fibrosis or actually decreased fibrosis upon on the drug treatment. So so I went very quickly on how we used this AI system for applications of several strategies for the applications. So some of the other issues is how fast and slow you can actually use a system to diagnose the diseases. So at the front line of the hospitals, for example, our system was implemented into several hospitals in Wuhan, which was the epicenter in the initial outbreaks in China. And it was important for the radiologists to actually be able to upload the images to the system and obtain a diagnosis very quickly. So we thought actually we can actually resize some of the images, DICOM images, and quickly, and then resize back to make a diagnosis. So those are some of the methods we use, and you can actually look at the in the details for the strategy if you like. So in summary, so we developed the AI system for the diagnosis of COVID-19 pneumonia based on chest CT. The system performed comparable to that of a practicing senior radiologist with significant clinical experience, and it can actually assist and improve the performance of a junior radiologist. And so I think this is actually a particular good example, an important point for an AI system, especially in an emerging disease. For example, if we have another Ebola virus or another pneumonia virus for pneumonia, it is important for us to quickly build a system that can be applicable and then can help the radiologist, even the senior radiologist who hasn't seen this type of lesions, to quickly bring up to speed. And we also did work on correlations of lesion features in a CT scan, as well as markers for multiple organ failures, and highlighting the multiple organ failure as an important feature of mobility and mortality. So for example, that we identified CRP as an important marker for organ failures. And then this is actually just to highlight the systemic inflammation as an important marker. In addition, we found actually a number of markers in liver, as for example, some of the transamylase and albumin and LFTs are important for progression to the severe illness, and also the D-dimers and the systemic coagulating functions are also important. So this is actually in the early stage of the diagnosis. Now we know that the coagulable state, or especially DIC, is an important factor contributing to important severe mobility and mortality in the COVID-19 patients in ICU. Obviously, so we also develop a prognostic model that can be used to stratify the patients, high risk versus the low risk patients, and this is important for physicians to identify those patients earlier and then intervene. So finally, we made this system open to all the radiologists and the clinicians, and then so you can download the slides and slices and also the codes. So this is actually now available at the China National Center for Bioinformation, and as it is now, it's being viewed almost 10,000 times and downloaded for now actually 3 million times. And so this is actually we're happy that a lot of people worldwide have been using them and for their actually diagnosis. We also are collaborating with several other leading institutions and in different countries to actually advance this and try to actually make combine data and the algorithms to make them more generally accessible and also applicable to the COVID-19 disease. So with that overview, I just want to acknowledge my collaborators, and so this is actually a collaboration with many institutions, and then I'll stop here, answer questions. Thank you very much.
Okay, very nice talk, Dr. Zhang. Thank you very much. So can you stop the sharing the screen?
Yeah.
Yes.
Sure.
We will invite the next speaker, Dr. Libertario Demi. Hi.
Good morning.
Are you there? Yeah. Great. Okay. Let me introduce the speaker, Dr. Libertario Demi first. Currently, he is an assistant professor at the University of Toronto, Department of Information Engineering and Computer Science. And he also is the head of the Ultrasound Lab, Toronto. As you know, okay, CT is the main imaging modality for diagnosis of COVID-19. However, ultrasound plays an important role as well. Ultrasound is everywhere. To be honest, I'm also an ultrasound guy, so I truly like this interesting and inspiring study. I cannot wait for this talk. So let us welcome Dr. Libertario Demi.
Thank you very much for the introduction. I will be giving this talk together with Dr. Van Sloan from Eindhoven, and we are collaborating at the development of deep learning algorithms for classification and localization of patterns of interest in lung ultrasound for COVID-19 patients. Well, the next slide. Well, basically, it's important to first look at these images. These are CT images, of course, but then what you see is that the alteration of the lung is basically very often at the surface of the lung. And this is very important because it means that we can investigate these alterations with ultrasound imaging. Because if the alteration would be only in the inside of the lung, that would not be possible to access it and evaluate it with ultrasound imaging. So the next slide. So here we see how the different alterations appear when you are using either a convex probe at the top or a linear probe at the bottom. And these are the two probes that we suggest for this context and in general for lung ultrasound imaging. Well, and what you see is that we defined together with clinical partners, national clinical partners, like Gino Soldati, Andreas Margiassi, Riccardo Inchingolo, Elena Torre, a precise scoring system. So we give the lowest score, which is scored 0. So you see the plots, the images on the left, to what is generally associated to a healthy lung. And what you see here are essentially horizontal artifacts. And these are present because when the lung is healthy, it basically represents an impenetrable wall to ultrasound due to huge acoustic impedance mismatch. And therefore the wave bounce back and forth between the probe and the lung surface. And this is the typical pattern that is then rendered by the ultrasound scanners. Differently, when you start to have alterations along the pleural line, which is indeed the line that is indicated by orange arrows here, and is the interface between the intercostal tissue and the lung. When you have alterations there, and so you have volumes that were before occupied by air and now they're occupied by liquid, fluid, or tissue, then you start to see this first alterations connected with vertical artifacts. And these are not specific for COVID, but nevertheless, they indicate the beginning of an alteration. Then if you move to score 2, then you have the more interesting findings. These are really consolidations. And these are now anatomical findings because really you see a significant part, especially speaking of the lung, that is not aerated anymore. And therefore also ultrasound imaging can properly visualize it. So it's not just an artifact, but it's really something that is actually present at the lung surface. And then you move at the end to score 3, which is the score where you have extended consolidations with associated white pattern. That is this speckle-like pattern that you can see below the consolidation. And that is basically due to the fact that you have loss of aeration, so ultrasound can penetrate, but then you have a very complex scattering environment where ultrasound waves generate multiple scattering phenomena, and this is how then the machine rendered them. So first of all, it was important to define a scoring system because you need to have at least something you can use as ground truth to train then algorithms. Then the next. But it's also important to see is that when we evaluate the score, we do it not just on a fixed position, but on multiple positions, like 14 positions. And that's because it's important to understand what part of the lung is most affected by the disease. And this was also interesting for us to correlate with CT findings that show that the posterior areas are those mainly interested by the pathology and those with the most severe alterations. And indeed, what we saw is that when you move from anterior to posterior areas of scanning, then you see a gradual increase in the score level and therefore a gradual worsening of the condition. Next slide. And this is just to show that if you would only look at the posterior areas, then you have an 80% in this patient population chance to correctly evaluate the worst score connected to this patient. While if you limit to the anterior one, you would only be obtaining a 24% agreement. This says that you need to evaluate across all the areas because also the posterior do not agree with 100%. So it's really important to have an understanding on where and how extended is the involvement of the lung. And this can be done with ultrasound by doing, for instance, accordingly to what we develop as an acquisition protocol, 14 acquisitions. Next. This is just some comment on the imaging settings, because of course, before you want to train a model, you want to have a data that is as standardized as possible. So again, we suggest the use of convex or linear probes, and in particular wireless probes when available. And these are the systems you see here in this image. So that's the entire system that connects wireless to an iPad. So that's very easily transportable, and it's also very easy to clean, which is very important in this context. Then use a single focal point, put it on the pleural line, keep the mechanical index low. It's not needed to blast the lung with ultrasound for no reason, especially since the pleural line lays around 2 centimeters from the skin, so you don't need to penetrate that much. Avoid as much as possible saturation phenomena, and of course do not use cosmetic filters, no specific imaging modalities. Achieve the highest frame rate possible, because motion is also potentially interesting to evaluate, and then store the video for further analysis. So that's the protocol we basically gave to the clinicians that acquired the data for us. Next. Then this is something I think it's important to touch on. We are not counting the vertical artifacts. And I know there have been some reports on the amount of B-lines correlating with progression of some diseases. The problem though with these approaches is that the appearance of B-lines is strongly dependent on the imaging frequency, is strongly dependent on the scanner and probes utilized and settings. So therefore, if you just would do that, there's a high chance that you would not have a reproducible method, because depending on the hospital that is using, depending on the operator that is using, you will have eventually the very same patient resulting in a different conclusion. So we are not focusing on the counting of B-lines. We are more focusing on the characterization of the patterns that we see. This is an example of an image of the very same patient in the very same moment, the very same part of the lung. On the left, with the same scanner, you have the image at 3 megahertz, and on the right, the one at 6. And there you clearly see that by just counting the artifacts, you will have very different end results if employing 2 different imaging frequencies. Next. Okay, so then the project is ICLUS. Well, and indeed the project here focuses first of all on the development of these acquisition protocol that includes the specific landmarks, that develops the scoring system. And then once we generated these data, we wanted to use artificial intelligence to essentially generate an algorithm that could score in real time or quasi real time these videos, so that also clinicians that are not expert in the evaluation of lung ultrasound videos could have access to the evaluation of these videos and also learn by the outcome of the algorithms. Next. So these are at the moment the institutes involved, or at least some of them. We have more than 16 institutes that are collaborating within ICLUS, including hospitals, universities, and research centers around the world. And next. And if we just talk about the data, right now we have more than 1,700 lung ultrasound videos. We are actually approaching the 2,000 mark. From right now essentially 200 patients. And the data set on which we developed the first algorithms together with Root is labeled frame-based accordingly to the 4-level scoring system. And we also have segmentations included, so pixel level evaluation, as well as video-based scoring, still accordingly to the 4-level scoring system. And overall, in this core database that we will release soon, we have 35 patients, 17 are positive to COVID-19, 4 were suspected, and 14 are healthy and symptomless, one of which was myself. And here you can see the percentage of the distribution across scores. Next. These codes are available through a platform. It's a web application. You have here the link, and where doctors can upload their videos and have them scored by the algorithms, have them segmented, and then they can also tell us what do they think. Do they think that the score was a good score, or do they think that in that particular video the score would have been different accordingly to their opinion? And this will help us a lot in improving the algorithms. Next. This is just to show you how the result of the algorithm would look like. So you see here 3 different videos, and on the left you have the video that the clinician will actually be able to acquire from a specific landmark on the patient. On top of that, you will have an indication of the score, frame-based, given by the algorithm. And then on the right, you have the semantic segmentation. So you have a color map overlaid on the image that is highlighting the location of the pattern of interest, as well as by color is indicating the score level. So either 0, 1, 2, or 3. And here you have some examples. And here I also want to acknowledge the other scientists that collaborated at the development of the algorithms. Yeah, then I pass it on to Ruth for the second part.
Thanks, Liebe. Yeah, nice. Yeah, I'll just spend a few words on what then the computer vision challenges were for lung ultrasound on our side. So we went ahead and yeah, started looking into this data and seeing if we could indeed translate the mind of the clinician, right, when they were annotating the data, into some kind of a computer algorithm based on deep learning. And some of the challenges that we faced were yeah, are listed here, and I'm going to go over them because I think they're relevant and interesting. So the first thing is that we saw unbalanced data. So of course, yeah, when you're acquiring data in the heat of the moment, and yeah, you can't choose who you're going to image, right? Then you're going to get some form of unbalance, and that's what we see here as well. So we see on a pixel level score distribution, we see that we have somewhat less pixels of score 1. and the others are relatively nicely distributed, of course, in a big background, which is 94% of the pixels. But you also see these differences across hospitals. So what is interesting is that for various hospitals, yeah, you see that score 3, which is the most severe case, is underrepresented, but on a pixel level, you actually see that it is quite well represented, and that already shows that these are pretty large areas usually in these kind of frames. So that's interesting to see. That's one challenge to deal with, and we dealt with that by simply in every batch, right, during training, in every batch, a balance across patients and scores. So every batch would contain a balanced representation across patients and the different scores. Then you are also dealing, of course, with an undersampled train data distribution with large redundancy across frames in a video. What do I mean with that? Of course, the full population of COVID-19 and healthy lungs is huge, and it's a huge distribution. And of course, this is a sample of that, and it's an undersample of the full population. And with that, so if you look at the number of frames, or the number of frames is huge, the 60,000 frames almost annotated. Number of videos is also pretty big, 277. But there's a huge redundancy within a video across the frames, right? So these samples are definitely not IID, which is which would be the optimal case, of course. And you see that also here in a video. This is one of such 277 videos, and you see that frames are quite correlated. So that's something to deal with. Then we see distribution shift across machines and settings, right? So these are two different examples. Yeah, you see a low contrast example on the left and a high contrast on the other side. This is simply due to settings, different types of machines, and that's something to deal with, right? So we get a distribution shift when moving from one image to the other, and that the algorithm has to deal with, the DeepNet. Noisy labels. Lung ultrasound imaging and interpretation of it is, of course, challenging, which is precisely why we want to do this, right? To ease the interpretation and to make it more standardized. But sometimes interpretation is so challenging that, yeah, it's even hard to, for a neural network to learn that. So let me give you one example of that. So this, you would say, has a missing annotation. Right? So this is the ultrasound scan, and here you see the annotations. And here you would say, okay, this is definitely an area that I would annotate. And actually, when we look later at the results of the neural network, that would be annotated as well. But the reason for these kind of things is that this area is not sufficient, was not sufficient to be scored as 3. But on the other hand, it was also not clearly associated to score 2, and that was why it was left blank here. And that yeah, tells you a bit about the how complicated it actually is to interpret it, and that the labels are in fact quite noisy because of that. And we also see that if you look at agreement among experts, so at video level, there's a 67% agreement. So that's definitely not perfect agreement. And lastly, boundaries between scores are fuzzy. And what do I mean with that? I mean that across space and frames, these boundaries are actually not very clear. So if you move from one frame to another, you could say, okay, this frame has this score, and the frame after is score 3, another score, but that boundary is a little bit fuzzy, right? So where do you decide to move from one score to another is not extremely clear. And in space, the same thing happens. So where's the exact boundary, exact contour of the artifact that we're seeing? That's not very clear as well. And one example of that is that we saw that dropping frames in between, say, these transitions, so these transition frames, led to a dramatic improvement of performance on a test set. So if you ignore these kind of transition frames, you get improved performance. So those were some of the challenges, and to deal with those, yeah, we did actually a lot of very strong data augmentation. So we applied affine transformations with a maximum of 15%, rotation of 15% as well. So those can be, if you think about it, at least for convex probes, rotation links very much to the appearance of these B lines that you see, or these artifacts. And they rotate the image because actually they are not anatomical, and they result from the, like Liebe was just explaining, they result from the echo being incidented on the pleural line, and there it can start to bounce around, and it starts to yeah, reverberate there. And that's why you see them very clearly in these kind of structures like that. And that's why we also applied some rotation to allow low-level features to deal with that as well. And then some scaling for changing the extent and shearing as well. We applied brightness augmentation, contrast distortion, lateral flipping, right? Because there's asymmetry, so that's something you can exploit. Gaussian blurring and adding some noise. So the contrast distortion and brightness, yeah, of course, they are clear if you look at the difference between systems, for instance, and you want it to be robust to that. So that's something that we did to improve on that. Then another thing we did is to step up in performance was to use model ensembling to increase robustness. So what we did is we used 3 types of networks, all trained with these strong data augmentation. A UNet, UNet++, and a DeepLab V3+. These are 2 much more advanced versions of the UNet over here. So the UNet++ is a specific type of UNet that has nested and dense skip connections, and it has a ResNet 50 backbone in our case. So it's a much more powerful network than the UNet itself. And the DeepLab V3+ has pooling features at different resolutions, and it uses address spatial pyramid pooling for that. And then all of those, they produce their own their own semantic segmentations with their own class logits and their own mistakes. And that's the nice thing. They have different types of mistakes. So if you then do per pixel softmax logits averaging, you get an improved result. So let's have a look at some of the videos. So this is what you would see. So indeed, you see 4 different examples here. You see score 0, score 1, score 2 to 3, and score 3. So these are different examples. You see a lot of blue here. These are these A lines that you see over there. That's a sign of a healthy lung. Here you see some green popping up, small artifacts that start appearing on the pleural line here. Yeah, and also some blue. So there are also A lines here. And here's a score 2 to 3, which you see switching from frame to frame. Sometimes it's red because the extent is very large and you see these consolidations. And sometimes it's much smaller and becomes score 2, which is orange. And this is clearly, here we go to orange again, so score 2, and this is score red again, which is a large extent of what I think people call white lung. Here are some A lines again. Yeah. Okay. So to some quantitative results, indeed you see that if you add on this online data augmentation, so during training, every time you change your data set and you augment on the fly, that you get a boost in the dice as well as the categorical dice. So this is a binary dice separating background and the healthy parts from the rest, so scores 1, 2, and 3. And this is categorical dice, including the scores 0, 2, and 3, excluding 1 because we had very little pixel level annotations of that. Then the UNet++ outperforms that. So you see that you get a step in dice and categorical dice. The DeepLab V3+ also does quite good. It's almost on par with the UNet++. But if you ensemble those 3, then you get an even better performance, and you see that you get to a dice of 0.75 and a categorical dice of 0.65, which is given the fuzziness of the labels, right? So the fuzziness of the boundaries and the transitions is I would say, quite a satisfactory performance already. So to say a bit about that, about this fuzziness, right? So here you see an example of an annotation, and you could say, okay, maybe I should have annotated until here, or maybe until here, or maybe just until there. And you see that as well if you look, so the segmentation does quite a good job here. It's a bit narrow, but other than that, it's quite nicely overlapped with the annotation. But what you see if you would do Monte Carlo dropout for uncertainty estimation of the semantic segmentations, then you see indeed this fuzziness of the boundaries coming back. So you see that there's quite some Monte Carlo based uncertainty along all of these pixels over here. And that's an interesting observation, I would say. So in conclusion, what we did is we developed a deep learning algorithm that allows for real-time, or in the web application, quasi-real-time assessment of specific lung patterns that are associated with COVID-19. And we did that based on the data set that is acquired in the ICLUS consortium led by Libertario. And that's the largest lung ultrasound COVID-19 database in the world at the moment. with annotations at video level, frame level, and pixel level. There's this web app also, that integration and that implementation effort is led by the University of Trento. And that has these deep learning algorithms integrated in the application. And for future directions, yeah, we discussed this, and actually one very important thing is that we get this to portable devices. So implementation on portable devices straight on the tablet is something that we are looking into, and of course, extensive clinical validation. And I think, yeah, one last thing needs to be said, and that is that this was really a collaboration between a lot of people, not just the two that were here. A lot of people worked on this, the students from the labs of Libertario, my lab, of Elisa Ricci, and all the clinical partners. So this was a major effort by many people. Yeah, so thanks to them.
Thanks, Dr. Dami and Van Snow. Great talk. Let's move to the next speaker and talk, Dr. Guo Taiwan. He is an associate professor in the University for Electronic Science and Technology of China. He's going to talk to us about a noise-robust framework for automatic segmentation of COVID-19 pneumonia lesions from CT images. So go ahead, please.
Okay, thanks, Timmy, for the introduction. And hello, everyone. So today I will present our recent work on the learning from noise neighbors for the segmentation of the COVID-19 pneumonia lesions from CT images. So as you know, CT images are very important for understanding how the lung is affected by the virus. The segmentation result can help us to know some quantitative measurements, such as the volume, the shape, and the spatial distribution of the lesions, and they can be used for accurate diagnosis. As also mentioned by Dinggang previously, the segmentation volume in different lung segments are very important features to distinguishing the COVID-19 from community-acquired pneumonia. And these features are also important for severity assessment, as well as longitudinal study and follow-up. If we segment the lesions and the lung lobes at different time stage, we can observe how the disease progresses and even predict the outcome of a patient. However, there are several challenges for the accurate segmentation. As you can see, there are a large range of appearance of the lesions. We can see some ground glass opacity, some consolidation, and also sometimes crazy paving. We can see the different intensity and different shapes, and the texture also has a large range. So here we can see the various scales of the lesions. And usually the images are acquired with different scanning protocols with various slice thickness. Maybe more importantly, it is very difficult to acquire large-scale accurate annotations for training because the radiologists can be very busy during the outbreak of COVID-19. So due to the limited access to clean labels, it may be practical to learn from some noise labels because noise labels are much easier and cheaper to acquire. So actually the labels can be noisy due to several reasons. First, there are some inter-observer and intra-observer variabilities during the annotation because different annotators may have their own annotation standards. Also, sometimes we can ask some non-experts for the annotation because it is very easy and cheaper to obtain, but these annotations can not be very accurate and they are noisy. Also, recently, human in the loop annotation is becoming increasingly popular, and as in this paper, we can use this strategy such as you just use a few number of images for training an initial model. And then we use the initial model to predict the annotations for the other images. And then we can ask a human to check and refine the initial annotations. So here the annotations may be biased towards the initial model. So it may also be noisy. So as theoretically, neural networks can fit any data. So if the neighbors are noisy, the neural networks may fit the noise. So the performance will be decreased. So in order to get a robust result, we need to find some strategies to improve the robustness against the noise neighbors. So actually in the literature, there are some works for learning from noise neighbors for classification tasks. First is a neighbor update strategy. So here we train an initial model and then use the model to predict some new neighbors for the training data. And then we can use these new neighbors to retrain the model again. And also sometimes we can use data reweighting, which is to penalize some hard samples because they may link to neighbor noise and only learn from some easy samples. And some loss functions, such as the mean absolute error loss, has also been shown as noise robust because such loss functions treat each pixels or each samples equally. They do not focus too much on hard samples, so they can reduce the risk of fitting the noise. However, most of these works were proposed for classification tasks, and actually learning from noise neighbors for segmentation tasks has not been well investigated. So in this work, we propose a noise robust framework for learning from noise neighbors for the segmentation of the COVID-19 pneumonia lesions. Here, our neighbors for the training were obtained by a human in the loop prediction with non-experts. So the neighbors can be quite noisy and not very accurate. And here, to deal with the noise neighbors, we use adaptive self-ensembling framework, which is also known as a mean teacher. We also propose a novel loss function, which is called noise robust dice loss. And as a minor contribution, we also propose a novel network, which is called COPNet, to deal with lesions antivirus skills. So in the following, I will give some more details. First, for the noise robust loss function, let's have a recap of the dice loss. So the dice loss is a very popular one for segmentation, and it can be formulated like this. So actually, you can see in the numerator, there is a mean square error term. Actually, the MSE loss is focused more on the hard samples because it assigns a higher weight to incorrect prediction. So it may be sensitive to noise because the noise often leads to incorrect prediction. But the advantage of dice loss is that it can deal with the imbalance between lesions and the background. In contrast, it sees the MAE loss. So the mean square, the mean absolute error loss just treats each sample equally. And previous works have shown that it is very noise robust for classification tasks, but it is not very suitable for segmentation and for large scale data set. So in order to overcome their limitations and make use of their advantages, here we propose a generalization of the dice loss and the MAE loss, so which is called noise robust dice loss and formulated like this. Here we can see there is a hyperparameter gamma. So if gamma equals to 2.0, actually it is the standard dice loss. When gamma equals to 1.0, it is a variant of the MAE loss. So, as I will show later, the optimal value of gamma is 1.5. So it is less sensitive to noise compared with the dice loss. And also it is more suitable for segmentation tasks compared with MAE loss. For the self-ensembling, the core idea is, I mean, teacher. So actually, This is a illustration of a standard mean teacher. Here we have two models. The teacher model and the student model share the same network structure, but with different set of parameters. The teacher model is updated as an exponential moving average of the student. So it can be formulated like this. Here there is a hyperparameter alpha, which is also the momentum of the teacher model. So due to the EMA, the teacher model can be more stable than the student. So it can be used to supervise the student. Here we have a consistence, which is used to encourage the student to learn from the teacher. And the weight of the consistence is also a hyperparameter lambda. And because the standard mean teacher was originally proposed for semi-supervised learning, when dealing with some noise labels, there may be some problems. For example, if the student is corrupted by some noise due to the EMA, the teacher will also be affected by the noise. It may also not be reasonable to always use the consistence because if the teacher performs worse than the student, using the consistence will drive the student to decrease the performance. So in order to better deal with the noise labels, we propose two adaptive mechanisms. The first is adaptive teacher. Here we set a threshold value of beta. If the loss of the student is beyond that threshold value, that means there is a high possibility of noise label. So we set alpha to 1.0. That means to do not update the teacher at the current step, so that the teacher will not be affected by the potential noise. Otherwise, if the student has a good performance with no segmentation loss function, we use the standard method to update the teacher. Here, the threshold value is a dynamic one, which is based on the performance of the student in a continuous case steps. We also propose adaptive student to weaken the consistence when the teacher performs worse than the student. That means if the student performs better than the teacher, it stops to learn from the teacher. Otherwise, the student is encouraged more to learn from the teacher when the teacher outperforms the student. For our network, it's one network based on the backbone of UNet with 3 extensions. Here first, we implement the downsampling by a concatenation of max pruning and average pruning. So this will naturally lead to a double of the channel numbers. Also, it will preserve more information compared with using a single max pruning. Also, we introduce some bridge layers to alleviate the semantic gap between low-level features in the encoder and the high-level features in the decoder. Finally, we introduce a ASPP module and the bottleneck to learn multi-scale features in order to deal with lesions, antivirus skills. So for experiments, we used clinic CT scans from 558 patients. So for the training data, we used human in the loop by non-experts to give the rotation. So the rotation can be very accurate and they are noisy. And for validation and test images, we asked the experts to provide manual rotation so they can be regarded as clean labels. The inter-slide spacing of the images ranged from around 0.6 millimeter to 8 millimeters. So we used 2D networks to deal with various inter-slide spacing. We split the test images into 3 groups of small lesion, medium lesion, and large lesion respectively to better understand how the model performs to deal with lesions and virus scales. So for experiments, we first investigate the hyperparameter gamma for our noise robust test loss. As I mentioned before, when gamma equals to 1, this is a variant of MAE loss. When gamma equals to 2, this is our standard test loss. So we changed the gamma from 1.0 to 2.0. As you can see, the performance will increase at the beginning and then decrease at a later stage. So here's the optimal value for gamma is around 1.5. So this is a generalization of the test loss and MAE loss, but outperformed both of them. So we set gamma to 1.5 in the following. To compare our method with other loss function, we first investigate the focal loss. So the focal loss is formulated like this. It also has a hyperparameter gamma, but typically the gamma is set as 2 in order to learn from some hard samples. But in our case of noise neighbors, this will drive the model to fit the noise. So actually the standard focal loss will have a decreased performance. But if we change the gamma to 0.5, that means to let the model learn from some easier samples, the performance would be better. However, compared with our proposed noise robust test loss, this variant of the focal loss still has a lower performance. So we can see that the proposed test loss outperformed the standard test loss. Also, it is better than a combination of cross entropy and bias, which is commonly used by a lot of segmentation works. And this figure shows the performance for different sizes of lesions. Here we can see our NRDS outperformed the others. And for the networks, we find that 2D networks perform better than the 3D one because the interslice spacing has a much range in our case. We compared 2D linear unit with attention unit and spatial and channel SE unit. But we find that actually it is very hard to beat the NN unit. So the NN unit performs better than the attention unit and SE unit. But when we used our proposed component, we obtained some improvement from the NN unit. Here, this figure also shows some qualitative result. So we can see there are some under-segmentation for the 3D network and 2D unit and attention unit. And our proposed component obtained better results. So for the self-assembly, we started with a baseline of just training our component with the standard test loss. So we observed that with a standard mean teacher, we can already get some performance improvement. But we further use the adaptive teacher and adaptive student, we can obtain more improvement. And if we combine them together, we can get a significant improvement from the baseline in terms of S and the relative volume error. And finally, the self-assembling is combined with our NRS, and we can obtain the more improved result. So we also compared our method with other noise robust methods. The first is data weighting. So that means we just learn from some easy samples and reject some hard samples. And this can actually lead to some performance improvement. We also used a neighbor update. Here we used an ensemble of 5 models to get the neighbor for training data. And then we use a new neighbor to train the model again for the segmentation. So, but we find that this is not very effective. And actually, with our proposed self-assembling with noise robust test loss, we can get a quite good result. So this figure shows the performance for lesions and different scales. Here we can see the advantage of the proposed method over the data weighting and neighbor update. So as a conclusion, actually, especially for large scale 3D images, it's quite time consuming and difficult to acquire very accurate rotations. Maybe a practical solution is to use some less accurate result, but they are much noisy. So in order to prevent the model being corrupted by the noise, we need to find some solution to become noise robust. So here in our work, we use our self-ensembling framework. We introduced as an adaptive teacher and an adaptive student to become noise robust. We also use a noise robust test loss, which is a compilation and generalization of the test loss and image loss. So we hope this loss function and the training framework can also be applied to learning from noise neighbors for segmentation of other organs or lesions as well. So finally, I would like to thank my collaborators and the reviewers and help us to improve the work. And finally, I would like to thank the organizers of this event, and thank you all for your attention. Thanks.
Okay, thank you, Wotai, for this great talk. Can you stop sharing your screen? Yeah. So that's invite next speaker, Changqing Zhang. He will talk about diagnosis of coronavirus disease 2019 with structured Latin multi-view representation learning. I think Dr. you can start. We cannot hear you.
Can you unmute?
No, I don't think he's unmute. No, he did not. But we cannot hear him. Yeah, his voice.
Can we move to the next one?
Vivek, yeah. Changqing, can you stop sharing your screen? We can invite the next speaker, so you can investigate the problem as well at the same time. So please stop sharing screen so we can invite the next speaker, Corona Shenlip, and she will talk about AI-assisted multi-stream data integration for improved diagnosis and prognostication in COVID-19. Yeah.
Thank you so much. Let me just quickly figure out how to do this here. Can you see my slides?
Yes.
Yes.
Yes. Okay, that's already a good start.
Yeah.
Super. Thanks a lot. Well, thank you all so much again, and in particular to Tianming for inviting me to this workshop and for giving me the opportunity to talk about the work we are doing here. I think I'm speaking for the whole team who have really enjoyed yesterday and the talks today. So thanks a lot for organizing this. It's a great workshop. So I'm Carola Schönlieb. I'm professor of applied math at Cambridge. And my role today is to give you a status update from the AIX COVNet team on ideas and preliminary results on our work on AI-assisted multi-stream data integration with the aim to improve diagnosis and prognostication in COVID-19. The objective of our work is to create an open source software tool to support COVID-19 patient management in the hospital. Our tool will be designed to take multi-stream data input, consisting of chest imaging data, X-ray and CT, as well as laboratory data and clinical data, which is then fed to what I call here AI algorithm, which is a set of tools consisting of machine learning tools, mathematical and statistical algorithms. And these tools then turn into the multi-stream data into appropriate predictions relevant for different diagnostic and prognostic clinical phenotypes, which then in turn are used for patient triaging, treatment planning, and hospital resource management. In this talk, I will mainly touch upon the imaging-related challenges that are involved in this endeavor and present some preliminary results and open challenges that we have encountered in the last 6 weeks or so in which we have been working on this. Our team consists of clinicians, biomedical researchers, mathematicians, engineers, and computer scientists who are all working together on this vision of this AIX COVNET multi-stream analysis tool. They are working both on the development of the clinical questions, the clinical phenotypes, the data collection and the data curation, the data processing, of course, and very important as well, the algorithm development. The team members come from the UK, in particular from Cambridge and Imperial, from Austria, in particular from Vienna, and from Germany, from Munich, with partnering hospitals and partnering companies from around the globe. So if you want to have a more comprehensive list of team members and companies, hospitals involved, please have a look at our website, which is cited on the last slide of this talk. I believe the strength that we have in our collaboration is really that we are developing everything, all these different parts, the clinical questions up to the algorithm development. We are developing this in very close dialogue between the clinicians and the data scientists, and everyone is really passionate about our goal. Now, for developing meaningful and impactful algorithmic tools for clinical support, we need to make sure from the very beginning that we are targeting the right clinical questions. In our team discussions and after a very thorough review of the existing recent literature, both on the clinical as well as the AI side, we identified the following unanswered clinical questions, which we believe are really crucially important for effective patient triaging and treatment planning for COVID-19 in the hospital. So these questions are: which patients need to be admitted to the hospital, and at what point during the course of the disease? Which patient need to be admitted for oxygen therapy in a general ward versus high dependency unit? Which patients will deteriorate and need admission to intensive care unit for invasive ventilation? Can we predict which patients will progress into a bacterial pneumonia, and when so, and also when, so we can adapt to the different situations with the treatment we are giving to these patients? Can imaging predict which patients will develop a heart versus lung phenotype? Can we predict which patients will get pulmonary embolism or microthrombotic complications? Can we use X-ray imaging to monitor the disease and its treatment? All of these questions, really, you have to see in the context of what already exists and what the clinicians at the moment really need in the hospital, in addition to the diagnosis of saying someone has COVID-19 or not. So exemplarily here, I'm picking up the last point on the X-ray severity prediction. So if you're looking here at this visual documentation of X-rays of a patient over a couple of days, you might appreciate the subtlety of COVID-19 biomarkers for X-rays, for severity in simple chest X-ray scans. The changes from very subtle line patterns in the first scan to consolidation and GGOs in the second, third, and fourth scan are very hard to quantify by eye, at least for me. And so hence the severity quantification based on X-rays, as one example, is clearly an area where AI can help, where really algorithmic automated quantification can help. So now, after defining the important clinical questions, our starting point for the algorithm development was, of course, in the review of the existing recent literature. So first, what are the existing imaging tools available for COVID-19? And here is a very incomplete list of a couple of, broadly speaking, AI solutions that have been coming out from both universities and AI and biomedical companies in the last months. What these tools can do is already very impressive, and given, in particular, given the short time we had to react to the pandemic and the usually small data these algorithms have been trained and tested on. However, despite these early successes, there still remain several gaps and open challenges in the algorithm development which need to be overcome before our clinical questions that I had a couple of slides ago can be answered with the help of AI. So here are a couple of those. The first one, again, relates to data scarcity. There are only a few public available data sets. Almost all data that are from that we have are from only a few sources, mainly from China. So data might not represent the global population. And another thing to consider is that COVID and non-COVID examples might be incomparable. The other thing that we heard yesterday already in Yong-Chul Ye's talk is that there might, we don't know, there might not be statistically significant differences between COVID-19 and other viral pneumonia in X-rays. We don't know. What are the boundaries of model performance? Most work that has been performed has been on diagnosis. So that's why I mainly left this out in my clinically unanswered questions that I had at the beginning. So as an AI challenge, what factors, what biomarkers, let's say in the imaging data, are important for prognostication and severity prediction? Also, almost all the existing work focuses on lung tissues. However, another thing to consider is that the heart potentially is also a very important organ for COVID-19 prognosis. So in this context, let me highlight some specific image-related open problems we need to address as a community. So first of all, the main focus so far has been on high modality imaging, such as CT. And this is very natural, due to the outbreak happening in China, where CT is predominantly used. This is in contrast, however, to a lot of other countries. For instance, actually most countries in Europe, where X-rays are used for both the screening and treatment monitoring. The next one is that we also had before with the data scarcity is the small data challenge. So we need to really develop models that can deal with small data, that can adapt to different situations easily, that can be translated, transferred in an easy fashion. And some keywords here are semi-supervised learning, transfer learning, patch-based approaches, again, such as in Yongchul Ye's talk, for instance, yesterday. The other thing that is already in our kind of embedded in our approach with this multi-stream data analysis is multimodality of the data. So we have different types of imaging data. We have different types of resolution, different types of how this data has been acquired. We have clinical data, laboratory data. We have longitudinal data also that has been acquired in non-equidistant time intervals. So all of this we need to find algorithmic solutions for. We need to find ways around how to deal with these very challenging types of data sets. And then the last point really highlights, is again not a highlight of what I said, that we really believe that this close dialogue between clinicians and data scientists is what is urgent, what will help us provide solutions to support COVID-19 patient management in the hospital, is that the models that we develop really need to be guided by the clinicians. We need to focus really on what is actually important to them, what they need. And here, if you look again, you will see the link at the end of the slides. If you look at our website, we are at the moment feeding lots of the things that we are learning along the way into this living review for AI-assisted diagnosis and prognostication on the basis of X-ray imaging. So now, turning from these very general considerations to the work of the AIX CovNet team, let me go with you briefly through some preliminary results we achieved in the last 6 weeks since we started. So we started approximately around the 23rd of March. We started, one has to say, however, from an infrastructure in Cambridge, where we are already very closely working, we as mathematicians are very closely working with the clinicians and the medical researchers in the hospital for the last 3 years or so in the context of our Malvern Healthcare Center. Anyway, so this work on COVID-19, we started about 6 weeks ago. And what I want to do now is I want to give you in particular an overview of the overall framework we have in mind for this multi-stream data analysis, and then highlight 4 individual components of it, namely the standardization of the imaging data. And here I will exemplarily show what we did for X-rays, lung pattern segmentation from CTs, in particular for feature extraction from CTs. Then another thing we thought about quite hard is this problem of missing data, of gaps in data, and how to deal with this varying data input constellation that we are faced with the hospital data. And then the last point is towards this link between heart and lung. So in particular, looking at a segmentation algorithm for calcifications from CT images. All right, so the overall framework first. So the overall framework for our multi-stream analysis roughly consists of two stages. The first one is a feature extraction stage, and the second one is a classification stage. The first one is all about data pre-processing and feature extraction for both the imaging data, okay, which could be X-ray, CTs, or both, but also the clinical data and the laboratory data. So for the imaging data, we are investigating some, first of all, for the feature extraction, some standard feature extraction networks. Then we also need to think about feature extraction for more complex clinical and laboratory data, such as longitudinal data, clinical reports, and so on, for which we are investigating both very classical feature extraction methods, such as PCA or something like this, as well as more bespoke feature extraction techniques. This step also includes this data cleaning and standardization step, as well as the data imputation, so the missing data step, which for the imaging data, for instance, needs to be done because the data might come from different scanners and so on and so forth. So this is the first stage. And the second stage is the classification stage. So here we want to classify into the different clinical phenotypes, which are then fed into a prognosis for how the patient is evolving, what kind of treatment steps we should plan for, and so on, what the resources should be in the hospital that we need to be prepared with for this particular patient, and so on and so forth. So here we are exploring currently two options. One is a fully supervised option, the other one is a semi-supervised option, very roughly speaking. While we are exploring both right now, we are very likely to be focusing more on the semi-supervised framework because it is likely to be more robust to small amounts of labeled data. It's amenable to handle also missing data. So in a way, we could treat the data imputation step almost as a component of the classification. And it also potentially allows in an easier way to discover new classes. Okay, so this was the overall framework. Now a few words about some of the specific things involved here. So first of all, about standardization of the data, of the imaging data. And here I'm picking out the standardization for the X-ray images. The first one is about standardization and enhancement. So as several speakers said today and also yesterday, one issue we have in the way for creating large data sets and algorithms which are generalizable is the change and the variability of the data across different hospital sites. Therefore, the standardization step is really a crucial one. So in particular, let me highlight that non-standardized measurements are potential confounders. They are likely a major source of overstated performances in some publications, as networks do not pick up the different clinical phenotypes, but they pick up the different CT scanners, for instance, used, or the different ways how the CT has been measured, and so on and so forth, or how indeed the images were reconstructed. So far, we need to do something about it. So far, we have investigated the standardization and enhancement for X-rays, and in particular, developing a solution that combines segmentation, cropping, and adaptive histogram equalization for the standardization part. And then for the enhancement part, we have looked at different filtering techniques, maximum or median filtering or something like that. So one nice thing about the approach that we have been looking at is that it is improving about the CXR resolution compared to existing approaches. And it also handles in a very nice way this issue here that you see here in the right corner, in the right upper corner of text annotations. So it does that actually, it handles that in a quite robust way as well. So the second example I wanted to present is about lung pattern segmentation from CT scans. And here I'm showing the results achieved by our team members in Vienna who have been developing a lung pattern segmentation tool in particular that we are currently fine-tuning for COVID-19. The approach is a UNet-based approach that works in 2 steps. One is the segmentation of the whole lung, and the other one is then the classification of the different tissues within the lung. Very roughly speaking, because I think I need to finish soon, in the figure on the right, what we show is a comparison between 2 results of Johannes's, who is one of our team members in Vienna, automated lung pattern segmentation, comparing the automated output when trained on this MedSec dataset, comparing this with the same algorithm trained on the LTRC dataset. And then we have just used this on our own dataset that we have collected with the help of all these hospitals that I've mentioned at the beginning. So what you see in these pictures on the right is, apart from the fact that the 2 have slightly different classes, what can also see is that the attention of the classifier is in roughly the same regions, with the MedSec trained classifier being a bit more conservative than the LTRC one. Of course, the results are quite preliminary, but they already show that this could be a very nice kind of additional, almost handcrafted feature for highlighting the important parts the classifier should be looking at afterwards. So the other thing I told you at the beginning is that we have been thinking a lot about data imputation. And here we have been focusing on roughly speaking, two types of methodologies. The one is when you take the incomplete data and you try to impute it before feeding it to the classifier. And the other one is to build a classifier that is robust with respect to gaps in the data. For the first approach, we are currently evaluating a relatively new deep learning based approach, which is called GAIN, against more well-established imputation techniques like mice or misforest. And we have some preliminary results that I'm happy to answer some questions about later, but I'm not going there in particular. In our initial tests, maybe just to say the more classically established techniques have been at the moment performing more robustly, but the GAIN approach certainly values more attention because there might be ways to make this more robust. Another thing we tried is this more robust classifier that can deal with the missing data. And here we have been in particular developing our own method, which we called robust forest, which at the moment I can't say more about because I'm not totally sure I'm confident yet to say how well it performs in comparison with existing approaches, but please stay tuned because if it performs well, there will be a paper that needs to be written soon. So one last word about this combination between, or this relation between lung and heart. So one thing to say here is that there is a lot of reason to believe that there are intercorrelations between heart diseases, cardiovascular diseases, such as pulmonary embolism, pneumonia, and heart attack, in relation to COVID-19, to COVID-19 related biomarkers. So what you see here is an example of the development of an asymptomatic coronary atherosclerosis during and after COVID-19 infection. So it's visualized here by a series of CT scans, where the top row is the overall chest imaging. The second and third rows are local views of a coronary atherosclerotic plaque. And the fourth one is a CT scan that shows mainly the lung damage during this progression through COVID-19. One thing we are developing together with our colleagues in Utrecht is to see if a method that they have been developing for calcification, for detection and classification of calcifications in the heart can be used in this context. So here you see some preliminary results that they have actually just literally sent us yesterday on detecting and classifying different calcifications in CT images in our data set. Okay, so what I showed you are quite preliminary results of a very active collaboration that is working on several bits and pieces towards this realization of this AI multi-stream analysis vision for COVID-19. Some immediate next steps from here are, of course, linking the analysis pieces for the X-rays and the clinical data for severity prediction and prognosis, doing a fine-grain analysis of clinical phenotypes on the basis of CT, and here also the lung and heart relation will be explored. Developing an analysis pipeline that is robust towards varying input and output requests. So we need to see which one of all these routes we are going to pick up. Semi-supervised training approaches are certainly close to our heart because we made a lot of good experiences with those in other contexts. So those will also be explored further for the COVID-19 related data. And then the last point that I didn't speak about at all, but that we are thinking about as well is uncertainty quantification for the algorithms that we are developing. So with this, I close, and just reminding everyone again of our overall goal to develop an open source tool for AI-assisted diagnosis and prognostication in COVID-19. And what is really close to our heart also with this open source, stressing the open source thing, is that we want to really bring this into the clinic in the quickest way possible. And again, here the open source in combination with the working very closely with the clinicians is crucial, I think. So thank you very much for your attention. Thanks a lot.
So thank you very much. Very nice talk. So could you stop share the screen now?
Yes.
Okay. The next speaker is Professor Qian Wang from Shanghai Jiao Tong University. Dr. Qian was graduated from UNC at Chapel Hill, and he was the chair of MIX in 2017. Now it's your time. Welcome, Qian. Please share your screen.
Okay, so can you hear me?
Yeah.
Thank you very much for introducing, and I really appreciate to have the chance being invited here and to present our latest progress to you. And this is Qian Wang from Shanghai Jiao Tong University. And in 2017, our university has cooperated with United Imaging, and we have founded a joint institute for medical imaging technology. And since then, we are able to push up these active research cooperations. And this work is actually a product of such close cooperation. And during past months of some hard time, and as part of a big rapid response, we have caught up our team, our students, collaborators, and we have worked really hard to make some progresses in this research direction. So let's come to talk about COVID-19. We all know that it is critical to identify, to track and quarantine patients to fight against the pandemic of COVID-19. currently PCR is treated as the gold standard for making a final diagnosis. However, if we rely on PCR only, then there might be several issues. Among them, we have seen the shortage of testing capacity. If we are unable to deliver testing service in a sufficient number, then very likely we will have to leave many patients untested. So, and since the viral transmission speed of the coronavirus is really rapid, so we have witnessed cluster outbreaks that are occurring in many different countries again and again in the past several months. And another issue points to the false negative ratio. So even if a patient has developed some symptoms already, like fever, like coughing, and a PCR test could possibly return a negative result, then we will have to test and retest this patient for multiple times until we get a positive reading for this specific patient. At the same time, chest CT, it is relatively easy to deploy, and it is fast to get a diagnosis. And very importantly, the price or the economic cost for chest CT imaging is kept as being comparable to PCR, at least in China. And that is a very important reason CT has been recommended and used as a major tool for clinical diagnosis assessment of COVID-19. So here come up with some typical CT images. We know that there are many image features in chest CT, and these features are closely related with COVID-19. We can see that there's some GD, and sometimes it is showing to be a consolidation in the lung. The problem is it is still very challenging to make a differential diagnosis of COVID-19 with respect to many different types of infectious phenomena. So there's little CT characteristic that is specific with COVID-19. And for many image signs, they are overlapping across different types of pneumonia. So in this study, we set our goal as to classify COVID-19 and community-acquired pneumonia, or CAP, based on 3D CT images. So to perform this research, we have prepared a really large multi-center data collection. We have cooperated with 8 hospitals in 7 cities that are located thousands of kilometers apart with each other. And in total, we have 3,645 patients in our data set. And from them, we have collected nearly 5,000 CT scans. And all these images are thin slice reconstructed, and the thickness ranging from 0.625 to 1.5 millimeter. We further split these these images into 2 sets. The first one is for training validation. We will do a 5-fold cross-validation on this training validation set. And this set has about 1,500 patients and more than 2,000 CT scans. And the second set is coming from more than 2,000 patients with nearly 2,800 CT scans. Hospital. So means that if we train some model by using this so-called training validation set, and we then migrate this model to work with the second test set, and
Could you hear me?
Yes, I'm back. Yes.
Okay, you can continue.
Okay, so yes, we have collected a very big data set. We basically have about 3,600 patients, and we have nearly 5,000 CT images, and they're split into two sets. One is for the training validation, and the second one is for an independent test. So for classification, we have adopted the 3D ResNet as the backbone. And in image pre-processing, we have carefully processed all images. We use a lung mask to suppress these background areas, and we only preserve these lung foreground areas for classification. And all images are center aligned, and we further resample them to the size of a 256 by 256 by 138. And the HU window is applied to properly normalize intensity values. And we in the network, we have used the binary cross entropy as the loss, and the training is done with 4 Titan RDX GPUs. So obviously, with a trained network, one can compute the class activation map to check the responding feature maps that are varying across to different locations in the space. So we just move one step further to use convolution.
Chen? Hi, Chen.
Chen, can you hear us?
Hi, Chen.
Hi, Jun.
Yes,
Can you hear me?
just don't know. I don't know why, because yes, I can. I think I'm back online. So because like my network has been running pretty smooth for last 2 hours, I just don't know why when I came to do this report and it has some problem. But anyway, I hope doesn't bother a lot. So basically, the key point is that one can calculate the class activation map given a network, and we just go one step further to use evolutionary layers to do this calculation for this activation map. And we use mask of segmented pneumonia infections to supervise the calculation of this activation map. So in this way, we can compare the derived derived activation map with respect to the ground truth of the segmentation mask. So then the hypothesis is that when the network makes a decision to make the classification, the decision has to be done by considering the image features that come from these infection areas only. So all these other information that are coming from this background will be suppressed, will not be included into consideration. And in this way, we can successfully increase adoption of visual cues for to improve the interpretability of our model. Okay, so as we have seen that it is very critical to have this to have these infections to be determined precisely. And we have, fortunately, we have access to this in-house tool, and we use this VBNet to segment lung and infection respectively. And basically, this VBNet is developed from VNet, and it is specially designed for tackling the COVID-19. And some typical segmentation results from 2 COVID-19 patients are shown in the right. And you can see that these lung fields are very clearly segmented. And within the lung, we see some blue masks. They are just for indicating these infection areas. So regardless how large, large or small the
Then try it again.
Sorry, Chen Wang's internet connection is not stable. Probably he need to rejoin us. Yeah, here we go. Good.
Continue.
Can you share screen again?
Okay. Yeah. Okay. So we just use this tool. We just go into details of how image is actually appearing. So we apply this VBNet to segment all lungs and pneumonia infections in our data set. And then we just figure out that obviously in our data set, this COVID-19 case, usually they're showing more severe infection than CAP. If we quantify the severity by computing the volume ratio between infections and the lungs, and then we can draw the distribution of how these things are going like on the right. So basically for blue bars, it is the count. So the horizontal axis is about the volume ratio here between infection and lungs. So from left to right, we can think about the severity of infection is increasing. And for the blue bars, they are belonging to CAP patients. And you can see that a big quantity, a big amount of them, they are actually distributed on the left, indicating that a majority of the CAP patients actually have, not that severe infections. But for COVID-19 patients, most of them, they tend to have some very big infection. That means that they have some high volume ratio if we compute if we compute the ratio between infection and lung. So a data set which is quite biased, and if we design a classifier, if we train a classifier to do this classification job, then this kind of a volume ratio could be easily regarded as a feature that is pushing that is going to dominate the classifier. So and we know that it's not the truth because even for a COVID-19 patient, this infection is growing.
Sorry, lost his connection again. Chen, can you hear us? Chen, can you hear us? Can you hear me?
Hey, Jamie.
Yeah, I would suggest you to turn your video off.
Okay.
Yeah, just share your screen.
Okay. Is that fine?
Yeah, cool. Yes, good.
Okay. So then we have seen okay, so just continue. So we have seen that we have somehow imbalanced distribution of this infection size in our data set. So basically for COVID-19 patients, they tend to have like a big infections. And for these CAP patients, usually these infections are relatively small. So in this case, we want to design a classifier, and this classifier would not be dominated or biased by such a issue in our data set. So then we proposed. So then we proposed this so-called science balance sampling. So basically, we can train two networks. The first network is still trained in a conventional way. We have a ResNet backbone, and we have attention module enabled here. So we use uniform sampling to get data, to get training data, and then we derive a network that is showing on top of this figure. And on the bottom half, we adopt a new size balance sampling strategy. So basically, we have a distribution of data here, and use a threshold on the ratio between infection and lung to cut the data into the left part and the right part. So for COVID-19 patients, we have COVID-19 patients with small infection, and those COVID-19 patients with large infection. And for CAP patients, the same story here. We have a small infection group and a big infection group. So if we apply uniform sampling to, so in total we now have 2 diseases, and every disease has 2 groups. So in total we have 4 groups. If we apply uniform sampling to these 4 groups, we basically get to the network that is on the top of this figure. But we know that the sizes of these 4 groups are not equal. So basically for COVID-19 patients, most of them are on the right half, but for the left half group, the size would be small. So in science balance sampling, we just make sure that in each mini batch of this, when training this network, the mini batch would counting equal number of subjects from these 4 groups. So in this way, we'll be able to get rid of the infection, of the influence from this imbalanced distribution of the data, and we'll get a network that is showing on the bottom of this figure. So then we have 2 networks. Each of them would give us a prediction. And the next step is that we use some very simple ensemble learning to fuse these 2 predictions, and we get a final diagnosis result. And that is how our network is designed. So basically, we call it attention ResNet plus dual sampling. So basically, we have a ResNet backbone, and we have a attention module enabled, a convolutional attention module enabled, and then we have a uniform sampling to get the network number 1, and we have a size balance sampling to get network number 2, and we have 2 networks here. We have ensemble learning to fuse them together to get the output. Here comes the result. So basically, we have a training validation set, and in this training validation set, we do this 5-fold cross validation. And since we have, since for each fold, we will be able to build up a model, and we can apply this model to our test set. So our test set could be tested for 5 times, and so we'll be able to evaluate standard deviation across these 5 testing folds. And we just compare the, for example, the AUC on the training validation, cross validation, and the AUC for the test. We'll see that the margin between them is relatively small, indicating that we basically avoid being trapped by overfitting. And also this standard variation that is reflecting how the models coming from the 5-fold cross validation would work out on our test set. And this standard deviation is small, is also small, indicating that we have relatively some stable network. We have trained some relatively stable network, and these networks could deliver very similar result on a test set. And another issue is about the role of our attention module. If we compare, for example, whether if we enable or disable this attention module, we can compare these 2 first rows in this table. We see that the performance, if we look at the test set, we'll see the performance has increased quite a lot. So, and we have done this t-test to evaluate whether this improvement is significant, and the answer is yes. It just confirms that by enabling attention module, our network could be able to deliver some higher testing result. here are some more results. So basically, another important issue in our model is the dual sampling strategy. And we know that the conventional way is to do uniform sampling. By introducing the so-called size-balanced sampling, we are actually breaching some constraint, and we are more easily to be tracked.
Chen, we lost your connection again. Can you stop sharing and share again? Sorry, the internet connection from China to the servers in the United States has some problems. The internet traffic. Good, here we
Yes,
go.
can you hear me?
Yes, please go ahead.
Yes, okay. So basically, we can make sure that the dual sampling can largely keep the performance compared to uniform sampling. And at the same time, just as said, COVID-19 patients will have a relatively big infection. So the performance for the minority of COVID-19 patients with small infection would increase. And at the same time, the performance increase again for the CAP patients with large infection. And these patients actually minority in the CAP data set. So we have some further attention maps, because I think that because I'm also doing the broadcasting job. So if I'm doing this broadcasting job in the same time with my presentation, and if my
Chen, we lost the connection again. Can you restart your screen sharing? Sorry, we got some technical problems here.
So I think I've figured out the problem, because I'm doing the broadcasting job, and when I'm doing the broadcasting job and at the same time I'm doing my presentation. So if very accidentally I have some very big photo on my slides on a specific page of the slide, and then my network would have some problem, and I will get disconnected.
Yes, please go ahead. We lost the connection again, sorry. Chen, can you? Yeah, good. Sorry everyone, we got some technical problems here. I think it should be over very soon.
Yes, I think, well, I think the problem is because I'm doing the broadcasting job, and if I share my screen at the same time, because I have 3 laptops in front of me. So if I share the screen in front of me, if I share screen, then my network would got collapsed, and I think that's the problem. So I think the best choice for me to do is to skip to the conclusion, and I mean, for the paper, you can get easily can access it through archive, and it has been accepted to TMI already, and it soon be published. So once again, thank you very much for listening to my not so continuous talk, and apologize for this kind of interruption and then inconvenience. Thank you very much.
Thanks.
Okay, thank you, Chen, for this very good, great talk, but also very not smooth. Okay, so let's move on to the next speaker, Changqing Zhang, and I hope now okay, everything get back. So he will talk about diagnosis of coronavirus disease 2019 with structured Latin multi-view representation learning. This is also based on his paper accepted by TMI special issue.
Thank you, Guyen. Can you hear me?
Yes, we can hear you. Yeah, no problem.
Okay, thank you. Here I will introduce our work on multi-view representation learning for the COVID-19 diagnosis. This work is finished with United Imaging and several hospitals. Okay, we know that the current clinical experience shows that the nucleic acid testing have a very low sensitivity, especially in the early stage of infections. Fortunately, we can got a lot of chest CT images, and these images often contain effective information for diagnosis of the pneumonia. Okay, so it is necessary to complement nucleic acid testing with automatic technique based on the chest CT image. Here is some examples of the chest images with infection of COVID-19 and with the CP infections. According to these examples, we can find that firstly, for some examples or for some patients, they are very similar for the corresponding CT images between different types of pneumonia. Okay. So a question is, if we just use single view features or simple features, maybe it's insufficient for diagnosis. So in this work, we want to type of features may contain complementary information, so it will be beneficial for the subsequent tasks.
Sorry, Changqing, can you turn your video off a little bit? Okay. Traffic problem, internet traffic. Oh yeah. Okay, good. Thanks.
Okay. Specifically, we can extract the radiomic features and some handcrafted features. Of course, we can divide them into several groups according to their different meanings. For example, radiomic features can be divided into grid features and text features. The grid features are composed of the first-order statistics which describe the distribution of voxel intensity within image regions, such as maximum, minimum, median, and so on. And the text features are derived from some grade level statistics metrics. Okay, we should note that all these features are extracted after segmentation, so they can provide valuable local information. This information has incorporated expert prior. Okay. For this data, this is a subject. Okay, I can show the point. this is a subject distribution in terms of genders. We can find the number of male and female are comparable. Okay, but this is a subject distribution in terms of age. We can find the average age of the CAP subjects is much older than the COVID-19. Okay, it is easy to be understood. So the first nature idea is coming. What about the quality of these different types of features? We evaluate this from two different perspectives. Firstly, we visualize each type of features by directly mapping them into a low-dimensional space by using some dimensionality reduction method. Okay, for example, the famous TSNE algorithm. So we can find that all these features cannot well reflect the underlying classification or class labels. However, it is difficult to say that these features are not promising for classification because the visualization simply treats each feature with equal weight. However, in classification, we can learn different weights for different features. So we also conduct experiments by using different features on different classifiers. These classifiers are some very baseline models. Okay, from this figure we can find that the performance is not so bad as in visualization because it uses weighting strategy for different features. Okay, we can find another fact that the concatenated features, that is using all the features, combine all the features, achieves much more promising results. So we want to ask another question: is there any strategy or any model we can use or we can design to further promote the diagnosis accuracy? To answer this question, we propose our model. We call it structured latent multi-view representation learning. The main advantage of the model is the completeness and structured representation. Okay, the first one, the completeness means we can encode the information from different views. In our work, there are 7 types of features into a latent or a compact low-dimensional latent representation. How to achieve this? Okay, let's see our first step. In our first step, we call it learn, complete, and structured latent representation. Okay, for the completeness, we use a backward or degradation network groups. For each type of feature, we use 1 networks. The latent representation is randomly initialized. Then, if the latent representation can degrade through each network to a type of feature, then the information from this type of feature will be encoded into our latent representation. Okay, so we call it complete latent representation. Okay, for another property, we call it structured representation. Because in training we have data, we have class labels, so we want to use the label to guide the learning to make our latent representation have promising structures. Then it can be benefit for the subsequent tasks. Okay, to handle this issue, we design a non-parametric loss. This loss is very simple. It is a clustering-like loss. The detail can be found in our paper. Okay. So in the first step, we can learn the latent representation from multiple types of features. Okay. The second step, we call it learning projection from the original features to the latent representation. So how do we really need the second step? Yes, because in the first step, we need labels and original feature, but in the testing stage, there is no label. There's just multiple types of features. So we learn the direct mapping from the multi-view or multiple types of features to the latent representation. Okay. After the second step, we can learn a very simple classifier. For example, a 3-layer fully connected network to classify the latent representation based samples. Okay. So in the testing stage, given a subject with multiple types of features, we use the projection regressor to get the latent representation and then input the latent representation to the latent representation based classifier can go to the final results. Okay, we note that the completeness and the structure are very, very important for the model generalization. There are some works have shown that the reconstruction, for example, the autoencoder can help our model have more much better generalization abilities. And this structure, in fact, it introduces simple induced bias, so it will further enhance the generalization ability of our model. Now we will evaluate the effectiveness of the latent representation learned from our model. Okay, according to the training data, we can find that the learned latent representation is well structured, which is consistent with our ground truth classes. Okay, this is in training stage because the label, class label or ground truth is available. Okay. What about the performance in the testing stage? We can find that the left is the original testing data and the right or the subfig D is the learning latent representation for testing data. We can find that after the projection, our latent representation is very consistent with the ground truth. Okay, so we conduct experiments on different baseline classification models with the original features. We just concatenated all these features, all original features together, okay, and then use our learned latent representations. We compare them, okay. We can find that all the shallow models perform not promising. They are all below 19%. 90%. The neural network performed generally better. All methods which also use the latent representation on the neural networks further improve the results very significantly. To more comprehensively evaluate the representation, we ran different classification models. All these models are some baseline models with our learned representation and the original features. According to these features, we can find that according to these figures, we can find this model with all learned representation as shown as the yellow bars outperforms that using the original features. Okay, in all the metrics and in all by using all the baseline models, it validates the latent representation can be widely used on different classifiers. Okay. To evaluate the stability of our model, we run our model on different ratios of training data. Of course, the testing stage testing data set is fixed. When using a very small training data set, the performance is also promising, and with more training data, the performance is further increased in a big picture. Okay. So this is the conclusion. Firstly, we can find that multiple types of features is really effective and necessary. Okay. Secondly, neural network is very effective to explore the general or nonlinear correlation between the latent representation and the class ground truth. Okay, the third one is the structured representation and the preserving the intrinsic information, or we call it completeness, is very important. They are all very important. They can jointly enhance the generalization ability of our model. The last one is that all latent representation can be widely used on different classification models. Then promising accuracy can be expected. So if you design another advanced classifier models, you can try our latent representation, and maybe it will further improve the results. Okay, so compared to the end-to-end stretch, our model is not an end-to-end model. Okay, so but our model is quite effective and stable, where the possible reason include the complementary features, and these features incorporate expert prayer. Another reason is our advanced latent representation proposed produced from our model. Okay. Thanks. Thank you.
Thank you. Great talk.
Thank you.
So we'll move to the next talk by Dr. Viral Nelson. So he's going to talk to us about the building Dutch database of imaging and clinical data of COVID patient for the development and objective validation of AI algorithms. Viral, please.
Can you see my screen?
Yes.
Okay, perfect. Thank you very much. Thank you very much for the invitation. Great event. I could not join all talks, unfortunately, but great that this initiative is going on, and great to see so much research in response to the crisis that we're facing all over the world. So I would like to shift gears a bit, not towards the actual presentation of algorithms that have been developed based on image data, but an effort to try to build databases to build diagnostic and prognostic algorithms, because we feel there's a real need now for developing such databases. In a way, I think this crisis also has given us new opportunities, because we realize now how important it is for coping with this enormous pressure on the healthcare system, with good information and learning from data and doing AI, and having good access to data is crucial there. And one thing I hope is that some of the efforts we're seeing that are happening now in order to make data available for research will help us in other disease areas as well, and that also a number of good things will come of this crisis. So just go to the next slide. As a disclosure, I'm also involved, next to my academic position, in a spin-off company, Quantip, although we don't have any efforts in the field of COVID. So none of what I'm presenting today in the presentation is linked to activities in the company. So I think many of you work in the domain of AI and trying to learn from image data, relate image data to outcomes. And we've seen that these learning systems have been quite disruptive, and especially tasks like segmentation and classification are now done best if you have access to a large set of data. Still, if we are critical, the translation of this to clinical practice has been slow, and the reason is probably that we don't need image data alone in order to make a good diagnosis or a prognosis. And there's quite some challenges if you really want to implement AI in a very broad setting. So I think challenges we see in the health domain to really bring AI types of efforts towards the clinic is that only analyzing the images is not what we need. Often we have to take into account much more information and relate it to outcomes. And that means we need to collect much more than the images, and collecting data in a good fashion and making them accessible to learn from is a challenge. Then we see that human biology and pathology is highly variable, And if we collect data bias is very much a challenge. So if in the end we want to develop technologies that we really want to implement, the question really is if the outbreak that was starting in China, if we could learn from data from Chinese patients, can we utilize the same data at the moment that the pandemic arrives at the Netherlands, for example? Or should we have specific data from our own databases, because there may be some biases in the data, and we see that as a really a big challenge for introduction of these techniques on a global scale. And in the end, also, it's very important that techniques are integrated into the workflow seamlessly. So one of the things we've realized is really to make the promise of AI into impact in society. We need to start to work on a health data infrastructure in which all data can be reused. And in the Netherlands, we have started to make this a national effort in which we connect all institutes that are collecting data, be it both for research or for clinical practice, and to start to think about harmonization of data for reuse for research and innovation. So what we try to tackle is the enormous fragmentation we see of data, images, and samples, both in the healthcare chain and in research. The enormous lack of standardization in care and research, which make it difficult to reuse the data for AI development and validation. This resulting in the reliability and quality and reusability of data being poor. Also, and this may be different in different parts of the world, but definitely in Europe, there's a lot of unclarity. Sometimes there's much more possible that people realize, so whether it's correct or not, but there is a lot of concern under what conditions actually we can learn from data for AI solutions, what is needed in terms of consent, etc. So these are things that are sometimes obstructive for really trying to develop methods based on databases. So that's the reason for us in the Netherlands to start HealthRI, and this is not just an isolated national initiative. Of course, we want to connect to other initiatives around the world to be able to learn from data on a larger scale. If you look at the way we organized HealthRI, it's on the one hand a political organization. We lobby towards the government to ensure that the laws are in place and the policies and the finance in order to be able to reuse data for research. Then we want to actually build a data infrastructure. I will say a little bit more about it later in the talk, but the crucial part of that infrastructure is that locally we support healthcare institutes to make their data available, and that means that they make their data fair, which means they are findable, accessible, interoperable, and reusable, and that we connect them with a system which allows for distributed access and distributed learning. And then the idea is, if you do that, you want to support both researchers and innovators in order to access the data. So you want to build a portal for people to get access to these data sets. So in a way, it has been quite a challenge to build such a health data infrastructure. And what you see is often that it's easier to fund a specific research project than infrastructure for a research project. And what we've realized on the HealthRI side is that really making sure AI works in the clinic requires infrastructure and an infrastructure investment. And COVID has all of a sudden made this much more clear also for the politicians. So we all of a sudden have a lot of tailwind actually in order to support the initiative, because people do realize that COVID is going to be around for a while, and that our ability to learn from today's data in order to will be crucial to treat tomorrow's COVID-19 patient better. And what we also see is that there's many initiatives now that have started to collect data, address different types of questions. But to collect and find the right data is non-trivial. If I look at my own hospital, I am from the Erasmus Medical Center in Rotterdam, and we have a very well-known virology department, so they are quite active in the field of COVID. And because of that, we have no less than 85 studies that have now been going to the department that checks for ethical and legal reasons whether a certain study can be done, or a certain observational study. So in one hospital alone, we have 85 people that want to do observational studies on the data. And we see the same pattern in other hospitals. So we see great efforts, but also very, very scattered. And we feel some harmonization is needed to really make optimal use of the data. So that's why we, from the Health Rise side, try to connect these initiatives. So obviously imaging plays a role in there. This is one of the early publications. There's many more publications now. Some of them were referred to in the previous talks. And we see that there's also a lot of interest in what's happening on the molecular scale, and why certain patients, for example, obese patients, have a larger chance to get the disease. So it makes a lot of sense, if you see the current articles, to start to learn from image data combined with clinical data and combined with samples. So what we've done in the Netherlands is first try to provide an overview. This is simply a website of all collections, data infrastructure, initiatives, etc., that are around. Then one of the more important initiatives we think is about the clinical data and about the samples, because especially imaging data in a way is a little bit easier to reuse them. They're already gathered in an electronic fashion, but in the end we want to link our imaging data to, we want to combine it with clinical data and to clinical outcomes. And what we've seen in previous occurrences of epidemics is that it's often later difficult in order to reuse data. So one of the first things we started to do together with people from the FAIR initiative, and FAIR is this international initiative to make data reusable by adhering to standards and harmonization, is that we started to ensure that wherever data are being collected, we adhere as quickly as possible to the CRF of the World Health Organization, and also that we support institutions to map this eCRF to a machine-readable form, such that the data can be reused. So this project, the Voden project, is linked to the clinical data, with the idea that we harmonize at the start as much as possible the type of data that is being collected. And we see now that the cardiologists or the oncologists sometimes want to collect additional information, and the moment they want it, we add it to the CRF and try nationally to coordinate that, to ensure that we collect the same type of data at the different institutes, so as to be able to share these types of data. We're doing the same with the imaging data. So our idea is that we're not collecting imaging data for a specific study, but that we would like to build an observational database of image data that is being able as a sort of I would say a large database from which different observational studies can be supported. So in the different hospitals, we collect data according to the same eCRF. And if X-ray or CT data are being collected, we want to store this data in an XNet database. We use the same pseudonymization software, has been developed by 2 university medical centers, and we share it between different institutes in a way to pseudonymize the data in the same way. When we pseudonymize the data, we ensure that we give the same ID to the imaging data as the data that are stored in the clinical database, such that we can always link the image data to the clinical data. For example, if we would like to be able to link image data to how long people are at the ICU, or what is their chance to be at the ICU, that is still feasible. So in this way, you would like to have the same principle for clinical data, image data, and samples, such that you can reuse them. Also, on the European level, people start to work with this concept of a data platform and a data portal. This is a bit more from the molecular field, and there's some European infrastructure initiatives that want to ensure that all kinds of omics data that are being collected in different cohorts can be linked through between the different cohorts. And we are in the process of also linking our image data to these types of efforts, such that in a privacy preserving way, we can connect image data to clinical data to molecular data. So I think if you think about this concept on the national level, or in this case, for the image data, we go to a national database, but by definition, health data are often going to be scattered and be located in different institutes. So the overall concept that we try to build, and which we think hopefully after COVID can be used for many other applications as well, is the combination of harmonization at the source, ensuring we have, and we call them sort of local data steward teams that ensure that the image data, samples, and clinical data are collected in a similar form and adhere to a certain data format. And then they are what we call fair data stations, and we connect the different institutes in order to be able to access the data, but also start to pilot experiments like, can we optimize a deep learning network with data staying locally, as long as the data have been clearly harmonized. So I think this is the direction we want to go, because by definition, data cannot always be pooled in central location. So I think a next important step is, of course, and I think that's what we're seeing now. I think there's a lot of great initiatives and a lot of algorithms are coming out in the COVID space, but it's still difficult to really know what is the quality of certain algorithms and how can a clinical end user know whether an algorithm that has been proposed can work beyond the data for which it is trained. So I think here our community has been very strong in the last 10, 15 years to build the concept of challenges and having objective frameworks to compare algorithms. And I think if we start to think of building databases, multi-center together for certain relevant tasks, I think also we should develop proper validation strategies together. And that's intrinsically linked to the databases we're building. So I think if we look at the Grand Challenge website that's maintained at Nijmegen University, you see the great history in the field of medical image analysis now, coming from computer vision to develop certain challenges. I think for many use cases, not only in COVID, it would be great if we start to develop these large databases, that we always set a certain part of the data apart, and that we define clinically relevant use cases, and are able that if we develop, if we provide this database, for example, for innovators and researchers to build algorithms on, we also ask them to utilize the same platform to evaluate their algorithms, so that we know what are the strengths and the limitations of algorithms, and we know how we can employ them. Now, I think there's a lot of collaboration needed there. Obviously, it's the companies that bring the eventual solutions to the end user, but I don't think companies can do it alone. This is a very nice paper by Michael Recht et al. From the International Society of Strategic Studies in Radiology that looked at what is really needed in order to bring AI to the clinic. And it really, especially on the part of having sufficient access to the relevant data, but also being able to validate systems in terms of what is needed in clinical practice. It requires co-creation between industry and clinicians. And there's also a crucial role there for academic medical centers, because they have data and the domain knowledge, but they need to co-work with industries in order to bring these solutions to the patient. So I think we see the enormous power of data-driven responses to COVID. We see it in the image domain, we see it in the molecular domain, we see it in the clinical data domain. And I think we have an important role to play there. But I think we also realize now for COVID, but also for all our other research, we are reusing our data too little. And that is because data are too fragmented and difficult to reuse. And I really hope that because of COVID, we're now starting a number of initiatives to share data between institutes, between countries, and between domains, and that this will be a stepping stone to really increase the quality of our research and the quality of the validation. And eventually, I think this will lead to more impact of AI in radiology and beyond. So thank you for your interest. And I don't know whether questions are answered now or whether we go forward to the next talk. Just let me know.
David.
Okay, so, thank you, Wilo. So Timmy, we're just going to the next talk, right?
Yes.
Okay.
Wilo, you might have some questions on the Q&A session on the Zoom, so you can type your answer over there. Yeah.
Okay, perfect. I'll check them. Thank you. Thank you very much.
Thank you.
Okay. So we are going to have the last talk for today. Actually, Dr. Babus from Department of Radiology in University of Pennsylvania. He's going to talk about how to integrate advanced medical imaging and computer science for fighting COVID-19. Dr. Babusa, can you share your screen?
Yes, I will. Thank you very much for the invitation. Let me just make sure that.
Wilo, you have to stop sharing, yeah.
Let me try again.
Okay, yes, you can share right now.
Okay, perfect. So thank you very much for the invitation. Let me just put my presentation here. Can you all see my slides?
Yes.
Yes.
So I am a thoracic radiologist from the University of Pennsylvania. I'm also a researcher. So I will present a different perspective. The goal of this talk is more to inspire and to present the problem from the perspective of a physician, rather than to present actual data or experiments. So the title is basically the synergistic role of advanced medical imaging in computer science, empowering medicine in the global fight against COVID-19. As I said, I will try to present the problem from the perspective of a physician, a radiologist who is in the front lines reading imaging studies on COVID-19 patients, but also a scientist that has some interest in AI-related research. I will discuss the role of chest radiograph and chest CT in COVID-19 differential diagnosis and management. And finally, I will propose a framework in which the medical imaging research community can work together with physicians to enhance the value of medical imaging in the global fight against COVID-19. So we all are very familiar with the challenges related to COVID-19. It's certainly the most serious global health threat since the 1918-1920 influenza pandemic. It has brought worldwide economic recession, immense human suffering, substantial loss of lives. And one of the problems of this disease is that it's a highly contagious respiratory disease that can be transmitted by respiratory means, droplets, and also fomites. And also, the majority of patients are post-symptomatic, meaning that they have no symptoms or mild symptoms, while still able to infect others. And while we know risk factors for poor outcomes, the clinical course is difficult to predict. So that brings the question of how to best allocate limited resources that we have. For example, who needs hospital care? Who needs ICU admission? We all know pathogenesis of this disease. I'm just going to briefly talk about this. We know that the virus uses angiotensin convert enzyme type 2 receptors to enter human cells. That basically allows the virus to access a wide variety of tissues in the body. For example, pneumocytes in the lung, respiratory epithelium, renal, GI epithelium, and the vascular endothelium. And that tells you a little bit about what it can do in the body. There's a very wide spectrum of illness severity. About 80% of the patients have mild or asymptomatic clinical courses. 15% are severe, and up to 5% have critical conditions that can lead to death. 95% or more of the patients develop symptoms within 10 days. It's very important to have this time frame in mind, because whenever we get an imaging study, it's important to know when the imaging was performed relative to the onset of symptoms. The median time from onset of dyspnea, which is shortness of breath, to hospital admission is about 7 days. And we know the risk factors for more severe clinical presentations, older age, multiple comorbidities, immunocompromised status. We also know that pneumonia is the hallmark of severe and clinical presentations. And in patients that have critical presentations, ARDS, oftentimes associated with cytokine release syndrome, is a common condition. So what's the role of imaging? We know that the definitive and the confirmed diagnosis of COVID-19 requires a positive PCR test for the virus. That's obtained via a nasopharyngeal swab. We can also test for other respiratory pathogens. And we also know that a positive PCR has a very high positive predictive value, which means that if you have a positive PCR, generally you have the infection. There are very few false positives. But we also know that the false negative rate is not that low. It can be between 20 to 50%. That also depends on the technique in which the sample is acquired, depends on the type of system that you use to identify the virus. So that may require us to do serial sampling in many situations. And we do that quite often in our hospital. That's something we have to emphasize. A negative chest imaging exam does not exclude infection with SARS-CoV-2, right? The other important consideration is that chest radiograph is the primary imaging modality in most countries, although some countries have used CT more liberally, even though chest radiographs are not sensitive and are not specific for the diagnosis of COVID-19 associated pneumonia. CT should also usually be reserved for complex situations and more problem solving, especially when you're looking for differential diagnosis. What else could be explained in the patient's presentation? Any contributory factors, any reasons for clinical deterioration. The Fleischmann Society issued a recommendation recently, April 2020, in radiology, in which they basically try to provide some guidance in terms of what and when to do imaging examinations. Their first observation is that imaging is not routinely indicated in suspected COVID-19 with mild symptoms, and that comprises about 80% of the patients. Once a patient has respiratory symptoms, especially worsening respiratory symptoms that require hospital attention, then imaging is indicated. And they specifically say that if you happen to basically live in a research-constrained environment, for example, if you have a lack of enough PCR tests, then imaging can be used for triage of patients with suspected COVID-19, especially if you have moderate to severe clinical features and a high pretest probability, means that you have a high incidence. And a high incidence of COVID-19 is essentially a global problem nowadays. Many countries have a very high incidence presently. So chest radiograph in COVID-19 should really be the primary modality. And most patients, as I said, have either a normal chest radiograph or they have findings that are unrelated to COVID-19. And we also know that most symptomatic patients will have pneumonia at some point. The chest radiograph is not very sensitive or specific, and there's a significant overlap with other infectious etiologies and also other non-infectious conditions. The hallmark of COVID-19 is basically when in terms of involvement of the lung tissue, the lung parenchyma, is bilateral airspace disease, typically multifocal. which is essentially pneumonia, a viral pneumonia. And also it's important to observe that it's not uncommon to have findings that are potentially related and findings that are likely unrelated to COVID-19 coexisting in the same patient at the same time point. So CT basically is, as I said, more sensitive, more specific. There are typical patterns that are suggestive of COVID-19 in the appropriate clinical setting. For example, when you have acute ground glass opacities that may or may not be associated with consolidations and interstitial thickening in a distribution that is multifocal and bilateral. And I will show some examples. It's more sensitive and specific than chest radiograph, but still, there are numerous differential diagnostic considerations that we have to entertain. It's also important that to realize that no CT findings can confirm or exclude COVID-19 with certainty, which means that the imaging findings are not pathognomonic, which means that there's always a differential diagnosis, even if the findings are typical for COVID-19. In order to maximize the utility of CT, one needs to assess the following. It's very important to know the clinical context. So what are the symptoms? What's the date of like a symptom onset relative to when imaging was obtained? You always have to think about alternative explanations, comorbidities, the pretest probability, which basically refers to the current prevalence or incidence, in this case of the disease, of COVID-19, where you are. And then you also have to think about whether the findings are acute or chronic. And all of those like observations should guide any effort to develop artificial intelligence algorithms to basically look at imaging patterns. So I show this example, which is a real case. That's a patient that we saw in our health system. And you can see that it's a high quality PA and lateral chest radiograph that's absolutely normal. This patient had 2 days of fever and dry cough when this image was obtained. The patient was tested because there was suspicion for COVID-19 and the test came back, the PCR came back positive. So the patient was diagnosed with COVID-19 with a normal chest radiograph and was sent home for self-quarantine because he had relatively mild clinical presentation. But then I'll show 2 videos of what happens a few days later, and that's quite common in many patients. So for example, he came back day number 6 with worsening shortness of breath. And now you can see a very typical pattern of COVID-19 associated pneumonia, multiple rounded and peripheral ground glass opacities bilaterally with basal predominance. This patient was admitted to the hospital that day and then eventually needed ICU care. And that's the CT that you see 14 days after onset of symptoms. And you can see that the pattern is similar, but it's much more severe. There's more extensive airspace disease, which is basic ground glass consolidation. The percentage of lung parenchyma involvement has increased and the density has increased. This patient is much more symptomatic at that time. I'll just move forward. So that's another patient. There's a patient who has an underlying predisposing condition. The patient had bilateral lung transplantation, so the patient is immunocompromised. And you can see that this is a baseline scan done several months before. There's not much, but just areas of scarring in the lung bases. And then this patient comes with 6 days of cough and shortness of breath. And now you see faint, small areas of ground glass opacity, okay? And this patient was admitted to the hospital because of high risk due to lung transplantation, was tested for COVID-19. We confirmed the diagnosis by PCR. Day number 22, the patient is much worse, is in the ICU and has ARDS. This patient is intubated now, and you can see that the extent and the severity of ground glass opacity has increased. There's more involvement in the lung parenchyma, but the pattern is similar. It's just more severe with a greater percentage of the tissue involved. There's another example of a patient who also has a predisposing condition. This patient had a lymphoma, which is a hematologic cancer. And this is a baseline scan that is essentially normal 3 months before. And then the patient comes to the hospital, day number 9, with fever and respiratory symptoms, cough and dyspnea. And you can see that at this time, there are new areas of peripheral consolidation in ground glass opacities. This patient was tested and the PCR was positive for COVID-19. So that's another manifestation of COVID-19 associated pneumonia. And it's important to basically always, when you have a chance, to basically go back in time to see if the findings are new. Chronic patterns are much less likely to be related to COVID-19 than acute patterns. So that's very important. And again, this should interfere like the way we think about AI algorithms. This is a patient just to show you a more complicated situation. So this patient has metastatic breast cancer. And then she had the baseline scan that basically show small nodules. So you can see those nodules are basically solid, which means they're dense, but they also have areas of cavitation. Those are metastatic lesions. And then the patient came back with 3 days of cough, fever, and worsening dyspnea. So of course, the possibility of COVID-19 was raised. The patient was tested. And we saw some like faint areas of, that I'm showing here, ground glass and twin budge nodules that basically indicate bronchiolitis, which is an inflammatory condition. But the test came back negative for COVID-19. And the patient was positive for another virus, which is a rhinovirus. Just to show you that the differential diagnosis always have to be considered when you're basically evaluating those patients. The patient also had pulmonary embolism, which is another potential risk in COVID-19 that can also lead to increased morbidity and mortality. There's a hypercoagulable state that we are more aware that this is a complication of COVID-19. That's something also we have to basically think about when we deal with this disease. So that's the last case I'm going to show you, just to show you a pattern that's not likely to be COVID-19, even though it's an acute airspace disease. For this patient came with a chest radiograph, and you can see that this chest radiograph was done day number 7 after the onset of cough and fever. And there is like a dense airspace opacity, a consolidation in the left mid-lung. And you see that on CT, it's a left upper lobe consolidation, it's focal. Focal consolidations are not likely to be related to COVID-19. But the patient was tested, the test came back negative, PCR for COVID-19. Also, we did a respiratory viral panel, we also came back negative. This patient tested positive for a bacterial infection, a Streptococcus pneumoniae, which is a very common cause of bacterial pneumonia. The patient was treated, and you can see the chest radiograph performed 4 weeks later is completely normal. So this resolved with antibiotics. So in summary, I presented all these examples to show you the spectrum of COVID-19 associated lung disease, and also to show you that there are many situations in which it's much more complicated than just trying to detect airspace disease, because the patients may have pre-existing diseases or may have other conditions that are chronic and are not related to COVID-19, or the patient may come with a different type of infection. And there's some association of specific imaging patterns that I described with COVID-19. So the chest CT findings in the appropriate clinical setting, they are sensitive and they're model specific for diagnosis of COVID-19 associated pneumonia, but they do not replace the PCR. The PCR is the definitive test to confirm the diagnosis. Chest radiographs and CTs are very helpful to evaluate differential diagnosis. And also any other factors that may be contributing to the patient's overall clinical presentation, risk for clinical deterioration, and potential for like poor outcomes, such as death. Chest CT helps management in complex scenarios, especially when we have clinical deterioration. And here's where I'm going to basically propose a link to research ideas in terms of like how to tackle that, utilizing AI, artificial intelligence algorithms to analyze medical images, chest CTs and chest radiographs. I do think that the value of imaging may increase once we apply quantitative algorithms, as long as we can focus on addressing questions that are meaningful. And I would say that the most meaningful questions are basically characterizing the type of lung abnormality, what's the pattern, right? Because we know that COVID-19 causes airspace disease. It does not cause, for example, well-circumscribed nodules or bronchiolitis or cavitary consolidations. So that's important to recognize. And then the spatial distribution also matters. This disease is almost always multifocal and bilateral. So if you see a focal finding, which is basically involving just one region of the lung, it's unlikely to be COVID-19 unless we image the patient very early, which is also why you need to know when the imaging study was obtained relative to the patient's clinical presentation. And then the last question is basically how much of the lungs are involved, because that's where you can draw a parallel with what you're seeing in the imaging exams and other physiologic biomarkers. For example, the patients like a saturation of oxygen or markers of systemic inflammation. And then if you do that quantitatively and you measure that over time, then you have what very well may become a prognostic biomarker. So that's a framework that I would like to basically propose for artificial intelligence research utilizing quantitative CT and also quantitative chest radiograph in COVID-19. That was a consideration that was also raised in the very elegant prior lecture, which that imaging findings must not be considered in isolation. We need to know, and that's why it's important to collect and organize data. We need to know the clinical context. We need to know the patient's like risk factors, comorbidities. We need to know how the patient is basically evolving, when the symptoms started, when the imaging studies were performed, and we need to know the laboratory biomarkers that are relevant. For example, markers of systemic inflammation, markers of increased risk of pulmonary embolism, markers of like poor oxygenation, because that reflects physiology, but also impacts outcomes. Detection of airspace disease has a role in research-constrained environments for diagnosis of COVID-19. But we also have to remember that diagnosis will rely primarily on PCR, unless you don't have access to PCR, which is typically not the case in most countries nowadays. We may have not enough, but we do have, and that should be the confirmatory exam. Detection of like other types of diseases is relevant in the sense that it changes the patient's risk for poor outcomes. It's different if you're a relatively healthy, young patient that does not have any known or pre-existing condition, or if you do, in terms of like your risk of like a poor outcomes. And that's been shown in multiple published like papers that age and comorbidities are risk factors for like poor outcomes, including death. So, and also, I think it's important to take a holistic approach to quantitative chest radiographing and quantitative CT. Again, trying to identify not only the patterns, but also thinking about ways to characterize the spatial distribution, the extent of like a lung that's involved by the COVID-19 related disease patterns, and also the temporal evolution, whether the findings are acute or chronic, and how they're changing over time. So that brings me to my second proposal, which is basically how we can create a framework for AI-related research, utilizing quantitative CT and quantitative chest radiographs for prognostication, which is basically to try to predict how patients will evolve, so we can allocate care in a more proactive fashion. For example, we can preempt the deterioration. If we know that a patient will likely have a poor prognosis, there is no reason to send this patient home. We may have to keep this patient in the hospital from the very beginning. We may have to be more aggressive in our interventions. And then now we're having multiple clinical trials going on for medications. We're going to have trials for vaccines really soon. We also have to have a way to basically assess the effectiveness of those medications. And that's another opportunity for quantitative imaging research. So longitudinal assessment is crucial. Those patients are imaged typically at multiple time points. We're getting many more chest radiographs than we're getting chest CTs. But once a patient is in the hospital, we expect to see chest radiographs on a daily or semi-daily basis. So it's important to basically be able to look at whatever we are measuring. And if we measure, for example, the burden of airspace disease, we're doing that in a longitudinal fashion and correlating that with like other clinical and laboratory biomarkers. It's important to, again, differentiate. This approach is important because it differentiates acute disease from pre-existing chronic findings. You will offer potentially a quantitative CT or even a quantitative chest radiograph derived biomarker that may be helpful in prognostication. And I think that once we have that data, that becomes another element to inform statistical predicting models that can predict not only prognosis, but also therapeutic response. And I think that would be a major scientific contribution and a medical breakthrough in this pandemic. And finally, we have to always think about those three components: severity, change, and velocity of change, right? So severity basically means how much of the lung is involved by the patterns that are likely to be related to COVID-19 that we discussed before. How does it change over time, and how fast it's changing over time? So my last slide conclusion is basically that I do believe that artificial intelligence, computational imaging analysis, and medicine can work together in order to maximize the value of the information that's present in medical imaging. as long as we're able to address questions that are meaningful and relevant. Diagnosis of COVID-19 is crucial. And diagnosis with imaging is a part of the way, a part of the mechanisms by which we achieve a diagnosis. PCR is still going to be the cornerstone for diagnosis. But not only the diagnosis of COVID-19, but also diagnosis of like other conditions that may explain the patient's clinical presentation. Without accurate diagnosis and without taking into account the complexity of the patient, physicians are flying blind. And then there's less we can do to help patients. Prognosis is equally important because obviously, as we said, we have to basically be able to allocate resources in a wise, effective fashion, and also preemptively, I mean, trying to basically be more aggressive in patients that we know are more likely to deteriorate based on the results of those predictive models that we can build once you have those ideas and those tools. And AI and quantitative imaging biomarkers may really improve prognostication and evaluation of therapeutic response. And I think the ultimate solution to the COVID-19 crisis will come from people like us, physicians, researchers, who are basically trying to work with scientific ideas to help medicine such that we can have a final definitive medical solution. And I think that together we can win this war. So with that, I would like to thank you very much for your attention and open for any questions.
Thank you, Dr. Barbaso. Actually, you know, we will have comments from former MICA chair, Dr. Jim Duncan. Jim, are you there?
Yep, I'm here, Dingang.
Yeah, can you make comments for all the speaker and all the particular the questions or technical questions, clinical questions people are answering.
Okay, well, I'll try to make some coherent wrap-up comments for you, Dingang. First off, I like to thank all of the organizers, Dingang, Tianming, and Guoyan, for excellent two-day, or at least the 2 days I was part of and observing. I thought it was really good. The talks were great and some nice discussion. I think, and the speakers were wonderful, actually. I saw all of them yesterday and about several today. I think the last two talks struck me especially nice, Vero Neeson's talk and Dr. Barbosa's, Barbosa's talk. I think that I think it's kind of interesting that a lot of the work so far has really been looking at the radiology workflow and how you work with either CT a lot or maybe chest x-rays. And I think this is good, and there's nothing wrong with that. Certainly data-driven approaches can help, and machine learning can help the radiology workflow. But I agree with the theme of the last two talks, perhaps, or the conclusions, that I really think we need to work as a community beyond just images in isolation, and how do they integrate into a wider framework, especially related to quantification of disease and outcome prediction, or as the last speaker said, prognostication, I guess you could call it. So I think that's critical. And as we build some of these image analysis, machine learning algorithms, I think incorporating non-imaging information is going to be a key part of this. Many of us have been looking at this in different ways, including genomics and genetic-like information, but now different kinds of clinical readouts, like things like pulse oximetry, and even derivatives of some of the PCR information might be useful in our algorithms. So, I mean, I really, it's despite that we're all going crazy staying at home, I'm over my garage and been lecturing and things. I'm sure all of you have been. I think there's a lot of interesting and productive work going on, and this webinar showed a lot of it. So it's encouraging, and I hope the community can really contribute. One last thing I'd say, I'm sure Dingang, you've already mentioned it, you did yesterday, but I'd especially point out that for really current and interesting high quality work, this joint issue that Dingang and Tianming are organizing between IEEE TMI and our medical image analysis journal. I really think that's a groundbreaking direction to have these two competing journals collaborate on it. And I'd encourage you to submit your work to that. So thanks a lot, then, gang. Hope that was helpful.
Thank you, Jim.
Thank you, Jim.
Jimmy,
yes.
This time, can you make a conclusion, for today's talk?
Yeah, I think we had great talks, and I think over a couple thousand people viewed our webinars so far through 3 channels, either Zoom, YouTube, or Bilibili website. So I think this is just the start of the topic, the discussions. There will be, I think, many other follow-up research works going on, including the special issue, joint special issue TMI and the medical image analysis mentioned by Jim. I think we got a lot of work to do. So thanks for everybody's interest and attendance of this webinar. I think and I also want to thank all the speakers, all the panelists who contributed significantly to this webinar. So thanks, everybody.
Thank you. Bye-bye.
Thank you. Bye.
Thanks, guys.
Bye-bye.